Okay. So this is kind of a long PowerPoint. I apologize. We had just combined those chapters, so it looks a little daunting when if anybody printed it. I think it's like 80 slides or something crazy. Okay, can everybody see the PowerPoint?
Yes, ma'am.
All right, thank you. Okay, so chapters 19 and 20, this is nursing management of pregnancy at risk. So we'll just kind of go over some of the things that can unfortunately go wrong during pregnancy. Up till this point, we've pretty much talked about a lot of like the normal process and what we expect. And now we're going to start talking about things that can sometimes go a little awry and kind of what happens with those particular, whether it's a disorder or a chronic medical condition, something that develops. So, okay. So you guys already know that we're constantly doing these risk assessments. So we're trying to identify any medical risks, like something maybe that they came into the pregnancy with or developed throughout the pregnancy. So an obstetrical risk as well. We're always going to be developing a plan of care and then kind of changing that and pivoting as we need to. This helps us reduce morbidity and mortality and hopefully a reduction in lawsuits as well. All right, the first thing we're going to talk about are some bleeding disorders or hemorrhagic disorders of pregnancy. As far as like, if we talk about maternal deaths, which we're not going to spend a lot of time there, but the number one cause of moms dying is postpartum hemorrhage. So when we get to our postpartum at risk, we do talk about postpartum hemorrhage a little bit more, but I just wanted you guys to know that it really is a big risk and a big deal. Management of obstetric hemorrhage involves early recognition, really good assessment skills, and then being able to implement that resuscitation plan, whatever it might be. So we have conditions that we know are associated with like early bleeding in the first half of pregnancy, and then other conditions that typically cause bleeding later in pregnancy. So we'll kind of talk about some of those things. For early bleeding in that first half of pregnancy, of course, we have things like miscarriage or abortion, fibroids, which are those fatty tumors that can grow in the uterus, and they can be really, really large, take up a lot of space. Ectopic pregnancy, which we'll talk about, something called gestational trophoblastic disease or molar pregnancy, and then cervical insufficiency. I've got a few slides on that. Conditions that are associated with pregnancy or bleeding in later pregnancy would be placenta previa, placental abruption, and placenta accreta. These are just some of the things. So we'll talk more about all of those. Okay, so let's talk a little bit about abortion or miscarriage. This is defined as pregnancy loss prior to 20 weeks gestation. So if anything before that 20 plus 0 mark would be considered an abortion or a miscarriage. You may also see the term POC or products of conception. When you have a miscarriage, whether it's one that the woman passes on their own or maybe takes a medication for or has a procedure for, whatever contents come out of the uterus are called the products of conception or the POC. That's considered a surgical specimen, so we do typically send that off to the lab for testing. Sometimes they're able to figure out, maybe there was a chromosomal abnormality that can contribute to the loss or something like that. But a lot of times we just don't really know what causes miscarriage. But we do send it to the lab to try to get information when we can. Any kind of loss after 20 weeks is considered a stillbirth. When we have a 20-week 20 plus 0 and on, so 20 weeks, 0 days, exactly 20 weeks. Anything after that, when that baby is born, they get both a birth certificate and a death certificate, and we have to figure out a burial as well. So that burial depends on the patient. So they can decide to do like a hospital burial where the hospital kind of manages that, or they can take the baby with them to a funeral home. The funeral home can come transport the baby. They can do a like an actual funeral, like a traditional funeral or celebration of life. So there's a lot of decisions that have to be made, and we as nurses help them kind of navigate all of that. There are a lot of different categories of abortion or miscarriage, and so you may see these terms as well. So I wanted to introduce them. Complete, so a complete abortion would be that all products of conception are expelled. So everything, all the contents that were in the uterus are out now. So we don't have to worry about any retained products which could cause infection and bleeding. Everything is out. Incomplete would be that there is a portion of those products left inside the uterus. And so that needs to be identified. And usually you would have a D&C to go in and clean out the uterus. A D&C stands for dilation and curettage. What that means is they dilate the cervix a little bit. That way they can get their instruments up in there. And then there's suction that can suck out any of those products of conception. And there's something called a curette, which helps to kind of scrape out that lining. So that's the curettage aspect of it. A threatened abortion would be someone who presents with bleeding and cramping, but their cervix is closed, so they haven't started to dilate, but they're having some of those warning signs that they may be miscarrying. A missed abortion would be that this happens a lot when somebody shows up for their very first ultrasound and there is a baby in their uterus, but it does not have a heartbeat. So they haven't started that miscarriage process, but the baby unfortunately has passed away. So that's a missed abortion. And then recurrent would be having 3 or more losses just kind of throughout that woman's lifespan. And then inevitable would be we can't really stop any of these things from happening, but inevitable, like the cervix is opened, it's thinned out, the process has started, it just hasn't been completed yet. So inevitable. And I apologize for talking about some of these things. I'm sure some of you have experienced miscarriage or know someone close to you, so these things can be really sensitive. So I apologize. I want to make sure I'm having you guys know that I'm coming at this from a caring aspect and also like an educational aspect, just so you know kind of the terms and what's really going on inside that woman's body. Okay, and then an induced abortion would be, could be a couple different things. So it could be a voluntary termination of pregnancy by the woman. So that can either be like medical or surgical. So maybe she was given a prescription to terminate the pregnancy, or she has a elective D&C. So the D&C, once again, is that dilation and curettage. It could be a therapeutic abortion. So either for the health of the mom or the baby. It's best to terminate the pregnancy. And then elective is kind of the same thing as saying like voluntary termination. So just so you're kind of familiar with some of these terms and know how to navigate and use them. Okay, so another thing you're going to see is a SAB. So SAB, that means spontaneous abortion, versus a TAB. A TAB is a therapeutic abortion. So kind of in like our world as OB nurses, if you see TAB on somebody's chart, it usually means that they elected to have an abortion. Whereas a SAB is something that typically was a wanted pregnancy that unfortunately they had a miscarriage. So you may see those terms in someone's chart. So a SAB, spontaneous abortion, is most common in those first 12 weeks, that first trimester. Typically as nurses, we are the first person to kind of encounter this patient because a lot of times they do present with vaginal bleeding and cramping. Not always, as we've learned, there are missed abortions and things like that, but those are your typical presentation. How we manage this is, I think the most important thing that I don't even think I put on here is, unfortunately, we're in a situation where there's nothing that we can do about it. And that's really what our patients are usually looking for. They're looking for some type of medication or procedure, or you to tell them something that they can do to stop this from happening. And that's really, really difficult because unfortunately we don't have anything, medical advancements or whatever it might be. We just don't have anything yet to stop that. So kind of explaining that. Obviously, we're going to be giving a lot of reassurance and therapeutic communication, but as far as from like our nursing assessment and things like that, we're going to do pad counts to make sure they're not bleeding too much. We're going to order with our orders from our physician HCG levels a lot of times, so watching that pregnancy level, making sure that it's coming down appropriately. They may have repeat ultrasounds to make sure that the miscarriage was completed. Maybe some blood work like a CBC. If they are bleeding a lot, we want to make sure they don't get too anemic. Just having them rest as much as possible, pelvic rest, so no intercourse, nothing in the vagina. And then medication sometimes to assist with completing the miscarriage. So there's medications that we can give to help that woman expel those products of conception. And then sometimes they do need a DNC or that dilation and curettage.
Miss Megan,
Yeah.
I'm sorry to ask,
That's
and I'm sorry for anyone that's gone through this, but as an L&D nurse, you do facilitate right, in preparing them.
Yes.
Would that also go for when there is an SAB? Maybe the parents, I know it's kind of like, would you be able to help them hold that teeny tiny baby or?
Typically when it's 12 weeks, unfortunately, there's not a whole lot to distinguish as a baby. I know on ultrasound, we could see quite a bit, but that still is a very, very tiny little fetus. So a lot of times when that does come out, some people do see like a sac, but if they were to actually like look at that baby, it doesn't really resemble a baby at that point. Now, as you progress in pregnancy, yes, definitely. 16, 17, 18 weeks and on. Those parents, we encourage them if it's something that they want to do to hold their baby, to spend as much time with their baby. I think actually at either the end of this PowerPoint or the end of the labor one, I have a slide about IUFDs, which is intrauterine fetal demise. And that actually is a big part of our job. It's something that we don't talk about a lot. But if any of you do go on to work in labor and delivery, that will be very much a part of your job, that you take care of women who are experiencing loss. And it's very, very difficult, but such a privilege to be able to be with that woman during that time and that 12 hours or however long you have that patient. It's just really impactful and really special that she's allowing you to kind of be there during the worst day of her life, honestly. So I have a little bit about kind of things that we do to help with that, or just kind of like nursing things that we can do.
Thank you.
Yeah. Okay, so then other kind of nursing considerations for like severe bleeding or hospitalized patients. Obviously, we're assessing the amount of bleeding, any signs of shock. We're doing vital signs per protocol. Usually they're pretty frequent. And then we're always worried about infection. If our patient did have a DNC or a DNE is a dilation and evacuation. So that would be if she's further along in her pregnancy. So maybe she's 14, 15, 16 weeks, that baby is larger. And so there are different instruments that they have to use to help kind of get those products of conception and that fetus out of the uterus. So those are definitely more difficult situations. And just the whole experience is just really, really terrible. And this is also something that is graphic, but I do want to share that with those DNEs, sometimes we are able to get portions of the fetus to be able to get mom hand and footprints. I know that sounds really morbid, but that's something that can be really special to your patients, because they don't necessarily get to hold that baby, but they at least get to see that baby's little handprint and feet and different things like that. So that would be like a DNE, which we don't do a whole lot of, but occasionally that is a necessary procedure. So if they do have a DNC or a DNE, We're going to give them a little bit different, like home going directions, still, monitor their bleeding, monitor for infection, maybe a little bit more pain control. This can be a really painful, not emotionally as well, but physically as well. So pain control, pelvic rest, so nothing in the vagina, no intercourse, no tampons, nothing like that. And then we do talk about birth control if that's something that they want to have that discussion. It is typically after a loss or an abortion or a miscarriage, it is typically best to wait to try to become pregnant again until that woman has had a few cycles to kind of re-regulate and get her hormones back at those steady levels. Because sometimes what can happen is you have a miscarriage and then you try to get pregnant right again, and then you'll have another miscarriage because your hormones just aren't regulated just yet. And then lots of emotional support. Okay, so something I know I've mentioned here and there is an ectopic pregnancy. So this is a pregnancy loss as well. So this is where do we expect our little blastocyst to implant? Where's the normal place that a blastocyst implants?
The curve of the fallopian tube called I forget how to say it.
It would
Not
Or-
fertilization or
the
conception, implantation.
for the uterus.
uterus.
In the uterus. Yes. So we expect what, Tony, what you're describing is conception, where the sperm and the egg meet is in the fallopian tube. Then once they meet and they start making those cellular divisions and doubling and quadrupling, that changes the name of that bundle of cells from a morula to a blastocyst, and it starts to travel down the fallopian tube into the uterus. Once we're in the uterus, that blastocyst implants into that upper part of the uterus in the fundus, where there's a lot of blood vessels, that muscle is really thick. So implantation typically happens in the uterus. With an ectopic pregnancy, that does not happen. Instead, it gets stuck in the fallopian tube for whatever reason. And so that bundle of cells starts to grow and develop an implant in the fallopian tube. You can also have an ectopic pregnancy other places as well, like very rarely, but it does happen. You can have it in your abdomen. It can attach to the bladder, the bowels. There's some crazy stories out there. There was actually one recently of a woman who, I can't remember what state or where this was, but she went in, I think, for abdominal pain or something, and was found to have almost a term baby, I think like 36 weeks or something. And the baby was alive, and it was an abdominal pregnancy completely outside of her uterus. So that can happen. That's more rare to have it outside. But if it's in your fallopian tube, I know you guys, most of you probably, if any of you have seen a fallopian tube, they're very, very tiny. So as that bundle of cells grows and grows and grows, and it's very rapid with that growth, it will put pressure on that tube and eventually can completely rupture that tube. So that's what we worry about. That is a medical emergency, and both the baby and the woman would die if that was not accurately identified and corrected. So it's very dangerous. Okay, so this, let me go back to my slide. I went a little off book there. So life-threatening condition, it does happen in about 1.5% of pregnancies. I bet somebody in this class has had an ectopic pregnancy. They're more common than what I even really realized. How this shows up is the same as any other pregnancy. You're gonna have a positive pregnancy test. So you're gonna have positive HCG because you are pregnant. So this woman will take a pregnancy test at home. It'll come back positive. If she has a pregnancy test in the office, it'll come back positive because it is a pregnancy. There's nothing different about that. What is different is just the location of it. That doesn't change the hormone level. So positive HCG, that woman, as that pregnancy progresses, may experience some bleeding. Some do, some don't. Cramping. A lot of times, anybody who's been pregnant, you may have experienced some cramping. And so it can be kind of a vague symptom. Sometimes with ectopic, it can be unilateral. So if the ectopic is growing on the right side, the right fallopian tube, sometimes that's where they feel the pain is on the right side, kind of like a sharp cramping. Or left side if it's on the left side. But honestly, that's not always the case. It really can be very, very vague. They may have some If it does start to rupture or really put pressure on there, they may have some nausea, vomiting, feel lightheaded and dizzy. That would be if it's starting to rupture or has ruptured. You would have those more intense symptoms. So how do we diagnose this? It's a tricky diagnosis because if we're talking about like using an ultrasound, we really can't see with an ultrasound that gestational sac until that woman is about 5.5, sometimes 6 weeks. So you could go in with some of these vague symptoms. They could do an ultrasound and they don't see anything in the uterus. And if you're 5 weeks, that's kind of normal because everything's just so tiny that we wouldn't expect. And so they may send you home and just say, come back in a couple weeks and we'll repeat everything when we've had a couple weeks of growth to see. That same person can come in 2 weeks and then they look in the uterus and there still is nothing in there, but they will get their HCG level. If we actually get like a level and not just like a pea stick, we get a number. And if that number is really high, we can correlate that with weeks of gestation. So if we're seeing a really high HCG, we would expect to be able to see a baby in the uterus. If we don't see that, then that's a red flag. Oh, maybe this is an ectopic. If it's large enough, let's say this woman is 7, 8 weeks, then we can visualize this pregnancy, this ectopic pregnancy in the fallopian tube. They can see it growing, they can see the heartbeat on the baby, and it's in the fallopian tube. So what's so tricky is that we need time for everything to grow to be able to visualize. So if they do have any concerns, they'll start trending that HCG. So they'll have them come every 24 to 48 hours to get their HCG drawn. If they see that it's going up, 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 then they'll do an ultrasound. If they don't see anything in the uterus, then they start thinking ectopic and they'll just continue to do those HCGs and do that ultrasound until they can prove, okay, this is an ectopic. Once we have that diagnosis made, we've got kind of 2 options to manage it. If it's in the fallopian tube or outside of the uterus, we cannot let that continue to grow. Even though it is a baby and probably a very wanted pregnancy, it at this point is a danger. It is life-threatening to that woman. So we as medical providers have to stop that pregnancy. And it's very sad. It's sad for everyone. Nobody wants to end a pregnancy that was a wanted pregnancy, but for the safety of the mom, we have to in this case. So we can give, in certain circumstances, they can get a medication called methotrexate. Methotrexate is an injection, and it's typically used for cancer because cancer also is fast developing cells that replicate very quickly, and so is pregnancy. So that medication works on both of those things. Tony, that's not a stupid question. There is no way to re-implant that baby, despite what you hear in the news from politicians. You cannot take that implanted baby and just put it somewhere else. It doesn't work that way. It's very sad. If we could do that, we would definitely be doing that because, like I said, we as medical providers do not want to end a pregnancy that is a wanted pregnancy for someone. So we can do that methotrexate. And then the other option is to actually have a procedure, a surgery. So it depends on how advanced she is, how far she is in pregnancy. If we're really worried about rupture or if she already has ruptured, then they will do a laparoscopic procedure. Sometimes, but if it hasn't ruptured, they can just go open the fallopian tube, take out that gestational sac and close everything back up. And other times they actually have to remove portions of the fallopian tube or the entire tube. So then that woman has one less fallopian tube. It just came into your brain, not from the TV. I hear everything on TV, especially like about women's health, and I get very fired up about it because I'm like, you don't even know the medicine behind this. So anyways, I understand why people have that thought for sure, but okay, so those are kind of our 2 management options. Nursing care, of course, we're assessing the bleeding, signs of shock, preparing for any kind of surgery procedure, lots of emotional support. And they are at a greater risk of having ectopic pregnancy in the future because they have scar tissue now, or if they had their tube removed, it just changes the like anatomically, they've now been changed or scarred. And then it can affect fertility if they have that tube removed. What's something that's kind of cool though is that ovary, this is just like a really interesting fact. Remember, the ovaries are not directly connected to the fallopian tube. So women who, let's say your right tube had to be taken out, that right ovary still ovulates. And so what can happen is your left fallopian tube can sense that your right is ovulating, and it will circle around to the right side, and it can grab up that egg that the right ovary is ovulating. Super, super cool that our bodies can do that. Also, like, a little creepy that it knows that. Okay. So here's a picture of an actual ectopic. So this is kind of looking down. Here's your uterus. Here's a fallopian tube. Here's an ovary. And here's another fallopian tube. And here's a baby inside of that fallopian tube. So you can see how tiny these little tubes are. Pretty crazy. All right, so just some signs to watch out for would be sudden severe abdominal pain or pelvic pain, dizziness or feeling faint, pain in the right shoulder due to, like, if your belly's filling up with blood, and then pain in the lower back. So if your patient's having these symptoms, that's probably a ruptured ectopic pregnancy. That fallopian tube has opened up, and that is a true emergency. That person needs to get back for surgery immediately, or they could die. We've had a couple patients that came into the office for their ultrasound. We actually had 2 patients this happened to, and during their ultrasound, they were in the ultrasound room and they ruptured. Their fallopian tube ruptured, and so they passed out. These 2 different scenarios. They passed out. We had to call an ambulance. Both of those moms did live, but I just wonder, man, if that would have happened when they were at home or in the car. It may have been a different story. Okay, so let's talk about gestational trophoblastic disease. And this can be a couple different things. That's kind of like an umbrella term, but so they can be benign or they can be malignant or cancerous disorders. What happens is this person gets pregnant, sort of. So sperm and egg do meet, but it doesn't develop a baby. Instead, it has this abnormal trophoblastic tissue or like placental tissue that starts to grow. So sometimes you can have, this is also called a molar pregnancy or a hydatiform mole. Sometimes you can have a partial molar where there is still a baby that develops, but the baby often has like chromosomal abnormalities and is not a viable pregnancy. Viable means like it can survive and live and like be a quote unquote normal pregnancy. So a molar pregnancy, you have this abnormal tissue growth and it grows very, very fast. So those cells already are, rapidly developing in pregnancy. This is even more so. So they end up being like clusters of cells or grapes. They look like cluster of grapes. And that's the hydatiform mole is that group of those cells, those abnormal cells. They grow so quickly that they start to fill the uterus up, and the uterus gets bigger and bigger and bigger, way more than what it should. So we know that the uterus gets bigger in a normal pregnancy. This is like double what you would expect. So somebody who, they think that they're 8 weeks pregnant, they go in and they're measuring like 16 weeks pregnant because their uterus is so full of all of these huge clusters of cells, this abnormal growth. How this presents is a high HCG level. So their HCG level is through the roof. And oftentimes, because that HCG is so high, they have really severe nausea and vomiting, or can get that hyperemesis gravidarum because their HCG level is way higher than a normal pregnancy. They may also have vaginal bleeding. They can also have a lot of pain and discomfort, and they can actually develop high blood pressure or preeclampsia. So typically preeclampsia is not something that you can get until you're 20 weeks or later in pregnancy, but for this particular condition, you can actually get it really, really early. So you can get high blood pressure and preeclampsia, which we'll talk about later in this PowerPoint. So, and then that increased fundal height. So that uterus is really, really big. How do we treat this? So once it is identified, we need to clean out the uterus. So we need that dilation and curettage or that D&C. Sometimes it can be a hysterectomy, but oftentimes it's going to be a D&C. This is a tumor, or can turn into a tumor. It can become malignant or cancerous. So what we have to do is for an entire year after someone has had a molar pregnancy, they have to keep coming back to the OB office to get their HCG measured, because if we see that that HCG starts to go up again, we are worried that that woman has now developed this trophoblastic neoplasm. So this cancerous or this choriocarcinoma. It's a type of cancer that can develop. It can develop 15 to 20% of the time after having a molar pregnancy. Those are pretty high odds. So it's super important that they have close follow-up. They come back every couple of weeks for that HCG level for an entire year. That also means that they cannot get pregnant during that year. So if this is someone who was trying to get pregnant and then they did get pregnant with a molar pregnancy, now they have to wait an entire year and get their blood work drawn every couple of weeks. And then after that year, as long as they haven't developed that cancerous condition, then they can go ahead and try for another pregnancy. So pretty frustrating and really disappointing, because they presented as if they were pregnant and instead they found out they have this molar pregnancy. So this is this is obviously a cartoon version, but here's your normal, pregnancy where you've got that tiny little embryo. A molar pregnancy is this cluster, these grape-like clusters. And sometimes these can even come out. She can have these grape-like clusters come out the vagina and she can see them. Okay, let's talk about some other types of conditions that can cause bleeding. A placenta previa. So this is where the placenta, instead of being implanted nice and high in the uterus, it has implanted way down low near or over the cervix. So there are different types of placenta previa. It can be like a low lying, which just means that it's really, really close to the cervix. It could be marginal or partial, where it kind of covers a little bit of the cervix, or a complete that covers the entire cervix. So that placenta will be covering that woman's cervical opening. How this presents, so if your patient does have a placenta previa, they can have this painless, bright red vaginal bleeding. That's super important. That's a really common distinguishing feature. And a lot of times NCLEX will ask this question, or I will ask this question. If your patient has this painless, bright red vaginal bleeding, you should be worried that they may have a placenta previa, unless you've already ruled that out with an ultrasound. Okay, so how we manage this. This is just something that can happen. Placentas can, especially if you have like twins or triplets and there's only so much space for placentas to develop, you're more likely to have a placenta previa, because that's just the space that's left for them to grow. So how we manage this is we watch for bleeding. So a lot of times we count the number of bleeds that they've had. So maybe they had a really minor bleed at 26 weeks pregnancy. They were admitted, we monitored them for a while, the bleeding stopped, they didn't lose too much blood, the baby's still growing well. Then they have another bleed at 32 weeks, and it's a heavier bleed. And then we start to get concerned, like, okay, we probably should go ahead and just deliver this patient. So it really just depends. It's a patient-to-patient basis and depends on the provider, depends on the amount of bleeding. But regardless, the one thing that is true across the board is this person cannot deliver vaginally. Why can't they deliver vaginally? How does the baby come out vaginally? What's the opening that it comes out?
The placenta
Is it blocked?
If it's covering the cervix, then it's not able to come
Not
out.
blocked.
Yeah, so the cervix is being covered by the placenta. So the placenta is what's giving our baby all of its oxygen, all of its nutrients. It's removing all of that waste. So if our cervix were to start to open up, and it would tear that placental tissue, right? So that's where the bleeding would come from. And then our baby wouldn't be getting oxygen or nutrients. Our placenta would be getting torn open. And then our baby's going to what, go through its placenta to get out the cervix and not breathe that whole time? No. So you have to have a C-section. If you know you have a placenta previa, which a lot of times with ultrasound, we know this ahead of time, or if it's identified, when that person presents to the emergency room, labor and delivery, whatever, they have to have a C-section for delivery. All right, so nursing care, assess bleeding, prepare for surgery, monitor vital signs, fetal well-being, all of that's kind of the same. So here's just a little cartoon. So your normal placenta is nice and high. It can be on the front or the back of the uterus, but it's nice and high in the fundus. Marginal, you can see this placenta is really close to the cervical opening. Partial, it's covering a little bit of the cervix. This is also called like a, is it partial? I don't know. Yeah, partial previa or total or complete. Yeah, would be over the entire cervix. That's what I was thinking of. Total can also be called a complete. Okay. Another weird placenta thing is this abruptio placentae, which just means placental abruption. I don't know, I just call it an abruption because that's too fancy for me. This is where the placenta starts to separate from the uterus while the baby is still inside the uterus. So we still need that placenta. Remember, the placenta doesn't typically come out until the baby has already been born, and then we no longer need the placenta, so then the placenta comes out. With a placental abruption, baby is still growing in the uterus, and the placenta is starting to separate from that uterine wall. So obviously you can see how that could be very, very dangerous and cause bleeding. So this type of bleeding is a little bit different though. It's typically painful, and it's typically a darker red color. It's painful because the uterus, so as it starts to fill up with blood, the uterus starts to contract and cramp because it's filling up with blood. It's getting irritable. So you have contractions. It's really uncomfortable. And then it's a dark red color because a lot of times that placenta is up higher and that blood kind of hangs out in the uterus for a while and then finally makes its way down. And so it has a chance to change colors and become like a darker red color or deeper red color. But it's typically painful, whereas that placental previa is bright red and painless. So don't get those confused. This uterine hypertonus just means lots and lots of contractions, really irritable contractions. And then if it's a really bad abruption, that's going to mean lots and lots of bleeding, and that can lead to shock. If we know that somebody is having an abruption, we like to keep them on that external fetal monitor. So that's what that EFM is. So monitoring baby very, very closely. A placental abruption is not always the entire thing comes off. Sometimes it can just be a partial, so just a little bit of the placenta starts to separate. And that means that we don't have to immediately go to delivery. Instead, we can watch that mom and watch that baby and make sure that that bleeding isn't going to continue. Make sure that baby is still growing well. So if she's like admitted to the hospital, they'll do growth ultrasounds every couple of days, just to make sure that baby is still getting enough oxygen, enough nutrients to be able to continue to develop, that the bleeding has resolved, and that way nobody's anemic. So it really just depends on how significant that abruption is. Now, there are other times where it does completely pull away from the uterine wall. That's what we can see with trauma, a big car accident, if somebody hits their belly or falls on their belly, just that sheer force can cause that placenta to separate completely. Or I always think like patients who want to go on like rides, like roller coaster rides. That seems like such a silly thing, but the force of that ride and that jarring can actually prematurely separate the placenta. Another thing that's pretty common, unfortunately, is cocaine use, or certain drug use, but a lot of times it is cocaine. The woman will use cocaine outside the hospital, and then that placenta will just completely detach, and then a lot of times that baby does pass away or is not doing well and needs a full resuscitation and cooling blankets, and really, really dangerous. But so if we do identify like a full placental abruption, we would need to do a C-section immediately. That's a stat. So right away in that moment, we rush that mom back. So nursing care, we're going to assess mom and baby. We're going to prepare for surgery if needed. Monitor for DIC. Something that can happen is mom, her clotting factors no longer work, and she can go into DIC where she can no longer clot her blood, and then we're in a real big pickle. Lots of labs, so CBC, platelets, those clotting factors. She may need blood as well. So it just depends on how severe this is. So here's just kind of a little picture here. So your normal placenta is nice and high and it's completely attached. Marginal would just be a little bit pulled away right here. So most of it is still attached and able to perfuse. Partial, you could also have like a hidden partial here. So this would be like the middle of the placenta has started to detach, but the edges are still attached. That's kind of like a hidden placental abruption. And then complete, the entire thing has come off. Okay. Cervical insufficiency. This used to be called an incompetent cervix, so you may see that as well. So it just means that that cervix starts to open up and dilate and efface, thin out, before that person's really in labor. It just happens. It's usually painless. Maybe they have a little bit of cramping or some abnormal discharge, but a lot of times it's happening without them knowing. And often this does cause a premature birth and then the loss of that baby, depending on the gestational age. A lot of times this does occur in the second trimester, maybe when this woman's 18, 19, 20, 21 weeks, kind of those early weeks, and that would be before that baby is viable. So before that baby can be resuscitated by NICU. So it's just this gray area. So risk factors for having a incompetent cervix or cervical insufficiency would be somebody who's had any kind of surgery or procedure on their cervix, specifically a conization or a LEEP. So those are procedures that can be done if somebody has an abnormal pap smear and they find that they have precancerous cells. They can go in and remove those cells through those different procedures. And so they've had surgery on their cervix and part of their cervix has been taken away. So they're more likely to have this cervical insufficiency. And then some people, even if they haven't had that, they are just, for whatever reason, predisposed to having this. So if you have somebody who's had a couple of second trimester losses, this is just something that you may think about, that maybe they're just dilating on their own. How this presents is painless cervical dilation. They may feel some pressure or some light cramping, but it's usually not really a big deal. And then maybe some bloody show or some abnormal discharge. That's really what I saw most frequently, was like a pressure sensation. Like they'd be like, I feel like there's like a bowling ball sitting down there, or like a balloon. And then I have all this like really thick discharge. And then, you know, I would do the speculum exam. I'd put my speculum in there, and then I would be able to see that bag of water or that baby coming out their cervix. I think I have a picture, yeah. So how we treat this is with a cerclage. So here is kind of what you see. This is a speculum inside someone's vagina. This is a cervix, and this is a bag of water with some presenting part. I always think this looks like a foot, but I don't really know. So basically you put this in and you see that she is already dilated, and unfortunately, that particular picture, we may not be able to stop that. It just kind of depends. But that other picture on the right-hand side is a cartoon that's showing you a cerclage. So that's where they actually tie the cervix shut. And that cerclage, that suture that they put around there, stays in the entire pregnancy up until the time that they are term. Once they're 39 weeks, we can take that out, and then, they can have their baby whenever. Or if that woman starts to go into labor, which can happen, her body just kicks into labor. She starts having contractions. That cervix does start to try to open up even with that cerclage. If that happens, we actually have to take that cerclage out because we don't want that cervix to tear. So, because that can cause a lot of bleeding, really difficult to repair, very painful. So we actually would have to take the cerclage out, and just allow that process to happen. This one always reminds me of a patient that I took care of years ago. She had a cerclage in, and she was having tons and tons of pain, but she wasn't contracting. We couldn't palpate anything. There was nothing on the external monitor. She was having just so much pelvic pain. We weren't sure if it was her bladder, so we actually took her back to the OR and flushed her bladder to make sure that was okay. We did all of these things to try to figure out where her pain was coming from. We never really could identify it. But the OB, the doctor said, I have to remove this cerclage because if that's the source of her pain, I can't have her tear her cervix. So we ended up taking her cerclage out, and there for, a couple hours, it was fine. She was still closed and everything was okay. Her pain did get better. And then all of a sudden she just had a ton of pressure, and I went in there and she was delivering her baby. So she was only 21 weeks, and I caught the baby in my hand. He was about less than the size of my hand. He was probably like this big. And he lived for just a few seconds and then passed away. But it was just a really terrible experience. And it was heartbreaking for this family because they had tried quite a while for a baby. It was just really awful, but I'll never forget that. Just part of the job, unfortunately. So our nursing care, if our patient does have a cerclage, is we're observing for any kind of bleeding, pain, or if their water breaks. Patients who have a cerclage are going to be seen in the office much more frequently. Pelvic rest, so they cannot have anything in their vagina for the remainder of their pregnancy. So no sex, no tampons, nothing in there at all. And then the cerclage has to come out if they do go into labor, and then lots of emotional support. That's a really scary thing to go through. Okay, let's see. Preterm labor. So this would be labor that starts before that 37-week mark. We have a lot of preemies that are born, and for whatever reason, the premature birth rate really has not decreased, despite us, trying to figure out what causes preterm labor. We're trying to stop it, but we just don't really know a lot about it still. Our goal is to try to get our babies to at least 1,500 grams, which is very small, or 35 weeks, and that helps us decrease the risk of them having respiratory issues and other issues as well. So how this presents is a lot of times they will have, maybe their water broke, or maybe they have some contractions or cramping. Usually it's pretty mild though, especially if they're really early in their pregnancy. It's not that characteristic like labor where they're super uncomfortable. They're just kind of crampy and they don't feel great. And then we're going to see that cervical dilation and effacement. Management. So it used to be that we put people on bed rest, but that doesn't really help. All it really does is set that person up for blood clots. So we really don't use that very much anymore. If we do have them on bed rest, we also have them on some type of prophylactic, they've got SCDs and maybe some Lovenox or something like that, but we really don't use bed rest very much anymore. We do have medications called tocolytics or tocolysis, which means to slow down contractions that we can give, but it really hasn't been shown to improve fetal survival. It can delay labor a little bit, which is good because then it allows us to give mom steroids to help develop that baby's lungs, and that actually has been shown to improve that baby's outcome. So just delaying that labor by even, 24, 48 hours can be helpful. So preterm labor contractions can be caused by dehydration or maybe some type of infection. A UTI is common. Some type of abnormal placental implantation. So something like with that placenta, abruption. So if it has started to pull away, remember I said the uterus gets really crampy and irritable because of the amount of bleeding that's in there. A lot of times this patient will call with kind of mild, infrequent tightening. If they do, if like you take this call from a patient, you're triaging them, we try to hydrate them, maybe have them rest, take Tylenol, do a warm bath, and then if things haven't improved within an hour, they need to call back and we need to bring them in to assess them, or if things get worse during that time. All right, so our nursing care, we're going to obtain a history. Have they had a preterm birth before? How much have they had to drink? Like, so we can kind of rule in or rule out dehydration. Do they think their water broke? Just different things like that. Are they having signs of infection? Like, urinary symptoms at all, which they don't always, even if they do have a UTI, pregnant women don't always have those classic signs. You can have them rate their pain. For if they are actually with you and we put those fetal monitors on, we can of course try to assess for those contractions. Depending on their gestational age, it can be a little bit difficult to monitor because those monitors are made really for women who are further along in their pregnancy. But if your patient's 22, 23 weeks, it can be hard to keep them on those monitors. But we can use our hands to palpate for contractions, different things like that. We're of course going to get a urine sample to try to rule out infection. A lot of times if contractions are present, but there's not significant cervical change, we will start an IV and give them a lot of fluid and see if that will kind of slow down those contractions. A lot of times that really does work. We may need to give some tocolytic medications to slow them down, and then lots of emotional support. I had preterm labor with both of my boys at 32 weeks on the dot with both of them. I do not know why other than dehydration. I'm always dehydrated, but for my first son, I got steroids, but it just resolved. The preterm labor resolved and I delivered at term. For my second son, I actually had to stay in the hospital for 24 hours and they gave me IV fluids and they just disappeared after a while, and I went on to have him term too. So I have no idea. Super weird. But I'm really glad that I didn't have a preterm baby. So for tocolysis, so medication that we give to slow down those contractions, probably the most common one is this terbutaline here. We give this in an injection. So it just really depends on the whole scenario if they would give you terb or not. But if we're contracting kind of back to back to back, not really getting any breaks, we've given IV fluids and it hasn't helped, then we'll go ahead and give this sub-Q injection of terbutaline. It's also called breathaline. It has an immediate onset, and it does help kind of buy you a little bit of time to get some more information, maybe get an ultrasound or some labs, but it does wear off very quickly. If the contractions continue, then we have some other medications that we would give. So depending on the gestational age, usually if you're less than 32 weeks, we can also give magnesium sulfate. So I know that you guys are familiar with just the name here, just through your math problems. So mag is most often used for preeclampsia, but we actually can use it for preterm labor as well. The dosing is a little bit different, but pretty similar. So it is a highly effective first-line parenteral agent. So it goes in through the IV. What it does, it's a CNS depressant. It blocks neuromuscular transmission to decrease seizures. That's the main thing. But because it does all of that, it relaxes smooth muscle, and your uterus is a muscle. So it helps to relax that big muscle so it's not contracting anymore. Also, because it helps with decreasing seizures, it actually passes through the placenta to protect the baby's brain as well. Those brains are still developing, they're really immature, they're very sensitive, and so getting that magnesium on board can help that baby's neurological system and also help decrease mom's contraction. So it's doing a lot of things all at once. So your dose dosage for this, it has a loading dose, just like what you guys are kind of used to with your math, and then we slow it down and do a maintenance dose. Usually with preterm labor, your loading dose is a little bit higher than with MAG. A lot of times it is a 6-gram bolus, or with pre-E, I'm saying the wrong things. So usually you have a 6-gram bolus, and then we slow it down to that 2 grams per hour. We run that bolus in very quickly within 15 to 30 minutes. This medication is nasty. It does not make you feel good. Anybody who's had this, you already know. It causes you to feel really hot and flushed. You're exhausted. You are nauseous. You just feel like crap. And it's pretty immediate. Like once we start that, you feel crummy. So I usually tell my patients ahead of time what to expect. I tell them, you're not going to feel great. Here's what we're going to do to try to help that better. I lower the temperature. I make that room as cold as I can. I give them a fan. I give them an emesis basin. I already have my Zofran on board. I take their blankets off of them, just have their gown on, and I just tell them, hey, this first 15 to 30 minutes, it sucks. Once it slows down, it still sucks. It just sucks a little bit less. It definitely gets better after that bolus. So I don't know. I'm just a person who I think honesty is the best. I don't want to surprise my patients. I don't want to start this medication. They feel like crap and they're like, hey, why didn't you tell me? Like, is this normal? Is this not? Causes them to panic a little bit more. So at least they know what they're getting. And then I also obviously tell them the purpose, like what it's helping with, why it's worth it to get this crappy medicine. So anyways, with magnesium, we do have to be careful with the level. So the therapeutic level is between 4 to 6. And that's something that we can test with their blood. We can get like a blood sample, like a tube of blood, send it to the lab. We want to watch out for MAG toxicity. So sometimes we can give too much of this medication, depending on the patient. Everybody, is different. So if we get too much MAG and we become MAG toxic, that can cause respiratory depression and diaphragmatic paralysis. So our patient can stop breathing. Normally, way before that happens, though, they already have red flags that we're going to be watching out for. Those would be changes in level of consciousness. So you'll go in to this patient that you've been chatting with and they're not really like responding to you. They're so drowsy. They don't really know kind of what's going on. They're really out of it. Huge red flag. You would stop the magnesium if you have anything like that. Stop it and get a MAG level. Another thing that we're going to see is a decrease in their deep tendon reflexes. So I know we haven't talked about those DTRs a whole lot just yet. We talk about them here in a little bit when we get to preeclampsia as well. So when we have a patient on magnesium, we have to assess their deep tendon reflexes. So that's like if you guys go to the doctor and they have that little hammer and they touch your knee to see how much your foot kind of jumps out, that's your deep tendon reflex. You also have them in your arms and hands and everything, but the knee is most common. So what you will see with MAG toxicity is they will no longer have that reflex. So you take your little hammer, touch their knee, and they no longer have that reflex. That's a huge red flag that they are MAG toxic. So once again, you would stop that MAG infusion, you would draw some blood, send that blood down to the lab, call your doctor and say that you're worried about MAG toxicity. How do we correct MAG toxicity? Once it's identified, we can give calcium gluconate. That's the antidote. So that would be a good thing to know. Calcium gluconate. All right. So our nursing care when our patient is on MAG, whether it's for preeclampsia or preterm labor, frequent vital signs, usually they're hourly, DTRs hourly, or if as needed, if you have any other red flags. On hand
you
on
cut
you.
out.
Hello. Can you guys hear me?
You're back.
Yay. Okay, sorry. It might be my internet. My internet's been a little spotty with this weather. Okay. Let me go back over here. All right, so some other tocolytic medications. This Ritodrine, I've never used this before. Nicole, did you ever use that?
No, I've never used Ritodrine either. I've only ever used terbutaline, honestly.
Yeah. Yeah, I don't know if maybe they got away from it. I just think it's strange because it's the only FDA approved medication for this,
Yep.
but we don't use it. So we use Brethine, which is an off-label use of that medication. So if we are giving terbutaline or Brethine, it's the same medication, side effects are going to be tachycardia, shortness of breath, increased blood pressure, some anxiety, feelings, nausea, vomiting, hyperglycemia, hypokalemia, arrhythmias, and pulmonary edema. So what I tell my patients, if I have to give Terb, I'm going to tell them you're going to feel like your heart is beating out of your chest, and that is a normal side effect. And like we said, it's a fast action, but it's doesn't really last that long. So just kind of telling your patient what to expect, and that way they're not as worried when their heart does start to race. We would not want to give this medication if we have someone with poorly controlled hypertension or issues with their thyroid or diabetes. So it just kind of depends on what their medical history is. We can only give this sub-Q every 1 to 6 hours, sort of just depends on your hospital protocols. And then there's the Ritodrine, but I won't have you guys test it on Ritodrine because I just don't know much about it, honestly. But Brethine is what I've seen at multiple hospitals used. Terbutaline, Brethine, same thing. Other medications that we can give to slow down contractions would be indomethacin or Indocin. We don't use this as frequently because of the side effects. So not just like the GI side effects, but really this premature closure of the ductus arteriosus. So remember, mom is still pregnant. So baby has that fetal circulation and needs those fetal shunts to, work as they're supposed to. That way baby can get oxygen to those most important organs. So if we give this Indocin, too much of it, and then we have a premature closure of the ductus arteriosus in that baby while mom's still pregnant, it's going to affect the blood flow and then the oxygen for that baby. So we don't really use that medication very much. Procardia we do use kind of frequently. So as I'm sure you guys know, Procardia or nifedipine is used for hypertension. So a side effect would be hypotension because we're not giving this for someone who has high blood pressure. We would be giving this to somebody who typically has normal blood pressure, but we're trying to give it because it's a calcium channel blocker. So it helps to decrease the action of the smooth muscle. So it relaxes smooth muscle. So it will decrease mom's blood pressure and it will also decrease contraction. So we just have to be careful that we don't decrease mom's blood pressure too much. But I have seen Procardia used quite a bit, like outpatient. They'll get a prescription for Procardia to be able to take. All right, and then I mentioned steroids, corticosteroids. So this would be Celestone is the most common one, or betamethasone is something that we give mom if she's having preterm labor and we are concerned about a preterm birth. We can give those tocolytics or try to slow down that labor. And while we're doing that, we're going to give mom these steroids. It's an injection. You get 2 of them, and it helps to expedite that surfactant production in the baby. And remember, surfactant is what keeps our alveoli sacs open so we can participate in that gas exchange. So babies who are preterm don't typically have surfactant or enough surfactant to where they're born preterm. Those sacs aren't able to remain open, so they have issues with respiratory depression. If we can give that Celestone, we can expedite that surfactant production and try to give them a little boost if they were to be born prematurely and help to develop those lungs a little bit quicker. So this is the only therapy that we have right now that we know does improve fetal survival. So like I said, usually it's this betamethasone. It's 12 milligrams. It's an IM injection that we give normally once every 24 hours. but you can give it every 12 hours as well. If it's like a really emergent situation where she's rapidly changing, they can give one dose at 12 hours and that second dose at 24 hours. But if things are kind of slow moving and we have a little bit more time, we like to space it out to one a day, one every 24 hours. And you can get that series of 2 injections twice during a pregnancy. So if you have like a preterm labor episode at 28 weeks, you can get Celestone. And let's say you don't deliver and then you have preterm labor again at 34 weeks, you can get another series of those 2 doses of Celestone. Okay, post-term pregnancy. So this would be defined as a pregnancy of 42 weeks or more. So that's like 2 weeks over their estimated due date. So our risk factors here would be this baby is very large and we're kind of running out of room, and our fluid levels, our amniotic fluid levels have now decreased as well. And so we can have more incidences of cord compression. That umbilical cord can get smushed a lot more and we run out of room, so it's getting smushed. So if we were thinking about fetal monitoring, what type of decelerations would we see, do you think? If we're having cord compression.
Variable.
Variable.
Yeah.
Okay.
Lots of variables. They also, because of that cord compression and because they're have low fluid, they're more likely to have less oxygen and nutrients from their placenta because their placenta is not working great. So they're getting stressed out. These babies are getting stressed out. So they're more likely to have a bowel movement and have that meconium pass while they're in utero. And then they're at risk for that meconium aspiration. So when they're born, they can take a big drink of that meconium and it gets in their lungs. These babies are bigger. So LGA, large for gestational age, which can lead to birth injuries, things like shoulder dystocia, which we'll talk about later. And then even fetal demise. So if that placenta is not functioning well, or if we do have some of that birth trauma, that can lead to the loss of that baby's life. So what we try to do is offer induction to deliver her earlier than that 42-week mark. But, you know, some women do not want to be induced. So what we would do is we would increase her prenatal visit. So we would do more frequent prenatal visits. So instead of once per week, she's probably going to be there at least twice per week for more antenatal testing. So things like NSTs, those biophysical profiles, growth ultrasounds to measure the fluid. So just to give us the whole picture of what's going on and maybe try to, sway her to have an induction. If we find out that her NST is not good and her biophysical profile, maybe she got a 4 on that, her amniotic fluid is super low, we can communicate all that to her and then maybe she'll be like, okay, yeah, I'll go ahead and have an induction. But still, people will decline and all we can do is just give them, information. It's ultimately their decision. Okay. What time is it? Okay, let's try to go to 11, then I'll give you guys a little break. PROM, so premature or pre-labor rupture of membranes. So this would be that the water breaks before that person goes into labor. If they are preterm, then it's P-PROM, preterm pre-labor of membranes. Lots of P's. So something that we need to note as nurses is the time that the water broke, the color of the fluid, the odor, if there is any, and then obviously our fetal heart rate. So as long as our, baby's doing well, then we can kind of assess all those other things. What we need to, if somebody presents with fluid leaking, it's not always amniotic fluid. So we have to figure out, okay, is it urinary incontinence? Is it a UTI? Is it a vaginal infection? Or is it amniotic fluid? So we have different testing that we can do to differentiate those things. So up here it shows you the nitrazine paper. So we could take a little sample of that fluid, dab it on this paper. If it turns blue, that could indicate it's amniotic fluid, but other things can also turn it blue, like urine, blood, semen, bacterial vaginosis, and trick. So this is not the only test that we need to use. We can also get a swab of that fluid put it on a slide and look under the microscope and look for this ferning pattern. So this is what amniotic fluid looks underneath a microscope. It looks like a little plant, like a little fern. You have to be pretty good at distinguishing that ferning from cervical mucus, which also has a little bit of a ferning pattern. It looks a little different, but you would have to be used to doing this type of measurement or whatever, assessment, I guess. We were trained on this at the hospital I worked at, but you had to train for a while and you had to be checked off on it. And that way you knew, okay, this is a ferning pattern. You can also use there's a test called an amnisure, which is a swab that you get of the fluid and you send it to the lab and the lab does a test. You can also do just like your, when you're doing a speculum exam, you put the speculum in, and if you see pooling, if you see a big bunch of fluid pooling in the vaginal vault, that can be a positive sign that her water broke, or you have her cough and you see the fluid coming out of the cervix. So there's just a lot of different ways. We kind of use all of that. Or a provider can do an ultrasound and measure the amniotic fluid. So it's not always the easiest thing to diagnose. So we have to use a little bit of this test and a little bit of this, and then kind of come up with our definitive answer if their water broke or not. So PPROM, preterm, pre-labor. It's also premature. They recently changed this to pre-labor. That's why I keep saying that. But preterm, premature, or pre-labor rupture of membrane. So it all means the same thing. So for this PPROM, it means that they are preterm and their water broke. Same diagnostic criteria. And both of these people are at risk for infection, chorioamnitis. So once your water breaks, the uterus is now open to the outside world, and it's more likely that bacteria can get in there, and that can lead to chorioamnitis, which is an infection of the sac around the baby. All right, so we like to have delivery if this is a PROM patient, so they are term, but their water broke. We like to have delivery within about 24 hours from that rupture of membranes, because we know that infection doesn't typically set in until after that 24-hour mark. If it is a PPROM, a preterm pre-labor rupture of membranes, it depends on how early that patient is. So if they are 35 weeks, then usually we just kind of let them go, see if they go into labor. If not, we'll augment their labor. But if they're less than 35 weeks, sometimes we try to keep them pregnant, because it's a risks and benefits thing. Which is riskier, to have this really preterm baby or to have her water broke for a couple of days? We can monitor, will she get an infection? Because not everybody gets an infection right away. So some people can go a couple days without an infection, and so that gives us a couple days that that baby can remain in utero and grow a little bit more, and we can get those steroids in and help those lungs develop. So it's all about the whole clinical picture and risks and benefits. So it's going to be different for each person. So also it depends on the hospital that you're at, what gestational age. So if you're at like a facility kind of out in the country, maybe you are not going to take care of preterm patients. That would be somebody that you would transfer to a larger hospital. But if you are that larger hospital, then you're receiving all of those high risk patients. So it depends on where you work. So corticosteroids, I mentioned that. So signs and symptoms that we want to watch out for regarding like infection or that chorioamnitis would be if mom gets a fever, or if mom is tachycardic, which a lot of times we're also going to see fetal tachycardia with that. We're going to watch her white blood cell count. And then also that fluid can have like a yellowish color and have a really foul odor. A lot of times you will be able to smell it when the baby is born as well. The baby also has a very distinct stinky odor because they've been swimming in that infection. Okay, polyhydramnios. I've mentioned this a couple of times. Polyhydramnios is when you have too much amniotic fluid. So a typical amount of amniotic fluid is somewhere around a liter, so 800 cc's to 1,000 cc's, somewhere around there. Poly would be somewhere between 1,500 to 2,000, if not a little bit more sometimes. I mean, you can have a lot of fluid. Some causes could be some type of fetal abnormality or like genetic condition or chromosomal abnormality, something with the baby's kidneys or GI tract or central nervous system. If you have multiples like twins, if mom has gestational diabetes, if the baby has erythroblastosis fetalis, so that the blood cells are getting broken down by mom, or sometimes you don't have any of these things and you just have a lot of amniotic fluid. So how this can affect the pregnancy is it can cause fetal malpresentation. So the baby is floating around in all of this extra fluid. So it has more opportunities to get into these wild, positions. And then with that, the umbilical cord can also get in some positions that are less than desirable. And then if her water does break, that cord can fall down through the cervix, and then we have a cord prolapse, which we're going to talk about later. It also puts so much more pressure on the uterus that placenta can detach due to the amount of pressure. So we can have abruption. We can have preterm labor because the uterus is so distended that it starts to cramp. And so then we have those contractions and preterm labor. How this presents is that the woman's size is greater than her dates. So she's 34 weeks pregnant, but when we do our fundal height, she's measuring 38 weeks. So her size is larger than her gestational dates are. Mom may experience even more shortness of breath and pressure and discomfort, and then edema, more swelling. So treatment, if it is severe, if the level's really high, then we can do an amniocentesis to drain that fluid. So that's what this picture is showing you. They put in a needle and they actually suck out some of that extra fluid. A lot of times what happens is that baby will continue to make more and more fluid, and so they have to have that procedure a few times to draw more and more fluid out. That's kind of a temporary solution because we're not actually fixing the underlying, problem that's causing that. Okay, let me just talk about oligo and then I'll give you guys a short break. So oligo is the opposite problem. So not enough amniotic fluid, so less than 500 cc's. What could be causing this? Maybe her water broke, or maybe there's an issue with the placenta, or something, once again, genetically with the baby. So we don't always have an answer, but just less than normal fluid. So your signs and symptoms are going to be the opposite. So your size is less than your dates. So you're supposed to be 24 weeks, but you're measuring 20 weeks because there's not a lot of fluid to make that uterus bigger. It results in cord compression. So we have less room for the baby in the cord, or less like cushion, I guess. So they're just crammed up against each other. It can cause decreased perfusion. It can stress the baby out so they can have that meconium aspiration or meconium in utero, and then it can lead to fetal demise. Treatment, delivery, if possible, really depends on risks and benefits. Maybe an amnio infusion, not typically, where we put more fluid up into the uterus. That's not typically something that we would do, like I had mentioned. Okay, why don't you guys take a little 10-minute break and come back at 11:10 and we will finish this
Okay,
out.
Miss Megan, can I ask you a question, please?
Yeah, of course. Okay, so I've got a couple slides on multiple gestation or twins, but this isn't something we're going to spend like a lot of time on because there's way too many nuances. Can you guys see my PowerPoint now that I switched back over?
Yeah.
Okay,
Yes.
thanks. Okay, so we do have quite a few twin, triplet, more births than we did in the past. I think a lot of that is due to like infertility treatments and things like that. Most common is going to be twins. There are different types of twins and different ways that we like conceive twins. So if they are considered monozygotic, that means that they came from one zygote, one egg, one sperm. So they are considered identical twins. And often you don't know this, like during the pregnancy, you don't know. Sometimes they can tell, sometimes they can't. But so monozygotic just means that they came from one sperm and one egg. Whereas dizygotic means that that woman ovulated two separate eggs, and then those eggs were fertilized by two separate sperm. And so those are fraternal twins. Those are just like any other siblings, a different egg and a different sperm. So those are dizygotic. And there are also, I don't know if I have, give me 1 second. I don't think I even go into, there are different types of whether they have one placenta, two placentas, one gestational sac, two sacs. So I don't even think I have slides on that. But if you guys want to explore twins more, you go for it. But we're not going to do it today. It gets a little confusing. So, okay, so presentation. So how this patient would present is that her fundal height is going to be larger than her dates because there's two babies in there. So the fundus is going to be larger. And then it grows faster. Also, like this is just kind of on this slide, it's like saying if you didn't have access to an ultrasound and you're like feeling her belly, you're going to feel way more small parts. So way more hands and feet than what you would expect. So that's what it means by too many small parts. Obviously, you're going to have two fetal heart tones or fetal heart rates. And then we're going to diagnose this with an ultrasound. Twin or multiple pregnancies are going to be at risk for a lot of different things, but preterm labor, this says PIH, that's an older term, but like gestational hypertension, preeclampsia, growth restriction, depending on if they have one placenta per two babies, that can cause a disparity like within who's getting more nutrients and things like that. And so then it can make the growth change. That's called discordant growth, where one baby is growing more than the other. They can have poly or polyhydramnios. That's what poly means. So too much fluid, poly. Our medical management, they're going to get more antenatal testing throughout pregnancy, more ultrasounds, more NSTs, more BPPs. A complication that can happen is twin-to-twin transfusion or TTS. And that is where one baby is getting too much and then another baby is not getting enough, and it causes issues in both of those babies. That's more common with our monochorionic twins, and that means one placenta, two gestational sacs. And it does have a higher mortality rate because they are sharing a placenta. In general, our nursing management for our moms of multiples, a lot of times they do have worse nausea and vomiting in the first trimester because their HCG is higher. So we'll talk to them about that. Physical discomforts are often worse. Maybe more of a financial worry or baby care worries. We're checking throughout pregnancy for any red flags for any of those like preeclampsia, preterm labor, things like that. And then each time that they are seen, we have to find both babies' heartbeats. So we've got two patients or two babies now to monitor rather than one. Delivery. So delivery just depends on the baby's positions that they're in, the gestational age, if the babies are tolerating labor, if mom wants to have a vaginal delivery or wants to have a C-section. If mom is trying to have a vaginal delivery, then we like the babies both to be head down or vertex. But I have seen twin deliveries where one is vertex and one is breech. So it depends on the hospital you're at, the provider, if they're willing to do that. Throughout labor, we have to monitor both babies. So they have another band around their belly to monitor babies. And then you're chasing both of them around, moving those monitors constantly. At delivery, we need 2 nurses, 1 for each baby, and then another nurse for mom. We need 2 baby warmers, 2 sets of resuscitation equipment. A lot of times we will have NICU or a special like newborn team there in case any kind of resuscitation is needed. And oftentimes what can happen is that first baby A can come out vaginally, and then baby B kind of does something a little squirrely, and we have to switch to a C-section. So oftentimes mom will have both a vaginal delivery and a C-section, and that's always a bummer. Okay, so let's talk a little bit about blood groups and blood types. And I know I kind of talked to you guys about like RH and all of that, so some of this should be a refresher, but just some pictures here if that helps you guys. So talking again about that RH factor, so we know blood types are A, B, AB or O, and then you're either RH positive or negative. So this is showing you that RH is a type of protein that can live on the outside of red blood cells. If you do have that, then you are RH positive. If you do not have that, then you're RH negative. And then our blood types also can have antibodies to certain other blood types. And so like when we're thinking about getting a blood transfusion, if we have A blood, we don't want to get B blood because A blood has anti-B antigens that would attack that blood from a B donor. You guys don't need to know all the ins and outs, but I'm just trying to kind of make some connections here. Okay, so this is kind of saying that same thing where you have those antigens against other types of blood. And then like there's different components to our blood, right? Like we have plasma, we have our whole blood. So really, you guys don't need to know any of this. This is just more information stuff. As far as like reactions that we would have if we got a transfusion, oftentimes it's that second exposure because at that point our body has created those antibodies and now recognizes that as like a foreign invader. But that's why we always do blood type testing. Even if that patient's already had it at another facility, if they show up at your facility, we will repeat their blood type because we want to make sure for sure what their blood type is. If they have to have a transfusion, we don't want a transfusion reaction. Okay, so revisiting our RH. So if we have that RH antigen on our red blood cells or that little protein, then we're RH positive. And that really, if you're an RH positive in the maternity world, for a mom, we don't really think anything of it. But remember our RH negative moms, we have to do something special for them. We have to give them that RhoGAM injection. So that's something that we always need to know ahead of time if mom is RH positive or negative. So we talked about what can happen if mom is RH negative and has an RH positive baby. So that's that hemolytic disease of the newborn or that erythroblastosis fetalis that can happen. So typically with your first baby, it's not an issue, which is what we've got here. So we've got mom who's RH negative. We've got a baby that we don't know it at the time, but this baby is RH positive. So mom goes throughout that pregnancy, and during that time, she starts creating these antigens or antibodies. And it doesn't affect this baby because antibodies take quite a while to develop enough of them to really do any kind of damage. But what happens is that second pregnancy, she now already has those antibodies in her bloodstream. So she gets pregnant again with her second baby. That baby also happens to be an RH positive baby. And now her immune system is already ready to go and it starts attacking those fetal red blood cells. So typically it's those subsequent babies that have issues, and we can have that hemolytic disease of the newborn where mom's red blood cells are breaking down baby's red blood cells. And that can lead to that erythroblastosis fetalis, which is hemolytic disease of the newborn. I know these are big words. So ISO immunization, that's the same thing we've been talking about here. So where mom is attacking fetal red blood cells. So what this can cause for our baby is anemia. So all those red blood cells are being broken down. When we have destruction of red blood cells, we get an increased amount of bilirubin. Remember, all that bilirubin can lead to jaundice. Jaundice, if it's high enough, if we have really, really high bilirubin, we have really severe jaundice, it can cross that blood-brain barrier and lead to kernicterus, which can cause neurological damage. So this is all like the most severe form of those things that we talked about. Those babies can also experience something called hydrops fetalis, which is what this picture is showing you over here. That's kind of a combination of things. So severe edema, these babies are really swollen. They can have pleural and cardiac effusions, hepatomegalia and splenomegalia, so enlarged spleen, enlarged liver, and then ultimately it can lead to death. So this is very, very dangerous if it gets to this point. Our management, like I said, we're going to get that blood type at that first OB visit. If this is her first pregnancy, we know that we're good. If we identify she's Rh negative, we can give her that RhoGAM. But if she's had other pregnancies and maybe she never got prenatal care, maybe she already has those antibodies. And now with this pregnancy, we're going to start seeing these signs and symptoms of this Rh isoimmunization. So repeat ultrasounds would show these abnormalities. So we might see hydrops in that baby. Sometimes we can do intrauterine blood transfusions, but oftentimes these babies are going to need to be delivered early. So here's that RhoGAM again. So just like as a refresher, it's an IM injection. All Rh negative moms receive 1 dose of RhoGAM at 28 weeks. Everybody, every single pregnancy at 28 weeks, you get RhoGAM. And then they will get another dose during postpartum only if that baby is Rh positive. Once the baby is born, we can test the baby's blood type. If it's Rh positive, mom gets another dose of RhoGAM. RhoGAM is considered a blood product, so there are certain patients that would refuse that, so we need to make sure that they're aware. RhoGAM, kind of how it works is it coats any of those Rh positive fetal red blood cells that may enter the maternal bloodstream, and it kind of hides them. So it kind of covers them, and so mom can't even see that they are Rh positive. She isn't able to see that little protein on those red blood cells, so then she doesn't create those antibodies. So that's kind of what's going on and what that injection is doing. When you give RhoGAM, it comes with a little card that we as the nurses fill out and we give to the patients, and that way they can carry that with them in case they get prenatal care at a different clinic or a different hospital. That way they know that she's got RhoGAM. Of course, people lose those all the time, but worth a shot. Okay, let's talk about some hypertensive disorders in pregnancy. And there are lots of different types of hypertension. So I want to make sure you guys don't get these confused and you kind of know the difference between them. So we're going to talk about chronic hypertension, which you guys probably already are aware of. You can also get something called chronic hypertension with superimposed preeclampsia. We'll talk about that. Gestational hypertension, preeclampsia, eclampsia, and HELLP syndrome. So these are all different variations of hypertension, and they're all diagnosed based on certain clinical findings. Okay, so chronic hypertension, one that you probably are all aware of, is when our blood pressure is greater or equal to 140/90 before pregnancy. So this is something that you enter pregnancy already knowing you have chronic hypertension, or you are early in pregnancy and you've come for a couple visits and we've noticed that your blood pressure is elevated above these ranges every time, and maybe you didn't know that you had chronic hypertension because you don't ever go to the doctor, and you're just now going to the doctor because you're pregnant, and we realize, oh, you have chronic hypertension, because before 20 weeks we don't typically experience any blood pressure changes unless it's a molar pregnancy. Remember I said molar pregnancy, you can get that hypertension or preeclampsia before 20 weeks, but typically if it's a pregnancy, the pregnancy is the cause of the hypertension, that's going to be after 20 weeks unless it's molar. So we can subdivide our chronic hypertension into like mild or moderate or severe. So mild, moderate would be somewhere around 140, 159 for your systolic, and then your diastolic 90 to 109. If it's above that, so if your systolic is 160 or greater, or your diastolic is 110 or greater, that's more severe range, more at risk for things like clots and stroke, things like that. About 25% of women with chronic hypertension will develop preeclampsia during their pregnancy. So that is a huge risk factor for developing preeclampsia. Antihypertensive medications are recommended if our patient is in that severe range with their blood pressure. So we'll talk about antihypertensives and when we use them and when we don't use them. Okay, so that was everything with chronic hypertension, things that you guys are probably aware of. Now, if we get gestational hypertension, this used to be called PIH or pregnancy-induced hypertension, so you may see that terminology as well. So gestational hypertension is something that develops after 20 weeks of pregnancy. So this patient entered pregnancy having normal blood pressures, and now she's greater than 20 weeks, and all of a sudden she has hypertension. She has no other symptoms. She just has hypertension. That is called gestational hypertension. One of the things that we're going to monitor is her urine. We're going to dip her urine for protein. If she gets protein, if she starts spilling protein into her urine, then it's no longer gestational hypertension. That changes her diagnosis to preeclampsia. So just remember that if it's gestational hypertension, that is non-protein uric, no protein in the urine hypertension. That's a very important thing to distinguish. So let's see, blood pressure would be greater or equal to 140/90 at least 2 separate readings that are at least 4 to 6 hours apart. They're very specific on this diagnostic criteria. So it can't be like you take her blood pressure, it's elevated, and then you repeat it 5 minutes later and it's elevated. That would not get her the diagnosis. But if you check it, it's 145/100, and then she comes back the next day for a blood pressure check and it's still, 149/100 or something outside of, normal range, that would give her the diagnosis of gestational hypertension. Gestational hypertension typically will resolve by 12 weeks postpartum. If that person is greater than 12 weeks postpartum and still has high blood pressure, they now have chronic hypertension. That would be a different diagnosis. That would be chronic hypertension. I know there are a lot of definitions here, so just make sure you guys star this, highlight this, understand this. Okay, so still talking about gestational hypertension. We don't know what causes this. We do have some like high risk groups. So if it's your first pregnancy, you're at risk, teen pregnancy, or an older pregnancy, AMA, advanced maternal age. If you're pregnant with twins or multiples, if you have gestational diabetes or an autoimmune condition, if you had hypertension in previous pregnancies, if you have a strong family history of hypertension, if you're African American, obese, or have certain lifestyle factors. Those are all just kind of like red flags for developing this. Our management is we do lots of blood pressure checks. So not only at your normal visits, but you may have to come back periodically to get blood pressure checks. And then we're always dipping that urine to see if you have protein, because we know that this can develop into preeclampsia, which is where the protein would come in. We also do labs, so we want to check those liver function tests and creatinine, because those things also, if they become elevated or outside normal, that would also change the diagnosis to preeclampsia. And then we manage this with antihypertensive medications. The only way to treat gestational hypertension is with delivery. So the whole issue is the pregnancy and the placenta, so we would have to deliver the baby. So it's all about risks and benefits. If we can control mom's blood pressures during pregnancy, and we can monitor baby's growth and baby's placenta is getting perfused and baby's growing like normal, then we can keep her pregnant. But if we cannot control her blood pressures, or if baby's growth and development is being affected, then we would have to do an early delivery. Okay, so let's talk about preeclampsia. So this is also hypertension, but now we have protein in our urine. Very important distinguishing factor. It's hypertension in pregnancy with protein in your urine, and then you typically will also have other organ dysfunction. It can affect any of the major organs: heart, liver, kidneys, central nervous system. For the pathophys, somewhat unknown what causes this, but we know that the underlying issue is a vasospasm and hypoperfusion issue. So what we have this vasospasm, which causes elevated blood pressures. With those elevated blood pressures, we have a reduced blood flow to those major organs, including the placenta. So because we have decreased blood flow to, let's say, the liver, for example, that impairs the function of the liver. So we're going to see mom with elevated liver function tests, and she may have pain, epigastric pain, which is underneath the right rib cage where the liver is. It can become painful. It also affects our clotting factors, which are made in the liver. So it's going to affect our clotting times. We also have decreased perfusion to mom's brain, which is going to cause headaches, blurry vision or spots in the vision. And then those deep tendon reflexes can be hyperactive. So you touch her knee with your hammer and her foot kicks out at you. So normal DTRs are +2. That's a normal little like kick out. This would be a +3, +4. They really come out at you. So hyperactive DTRs would be a sign of preeclampsia or something that can happen. And then we have decreased perfusion to mom's kidneys, which is going to decrease urinary output, and it's going to increase our kidney levels. So our sodium, our BUN, uric acid, creatinine. So all of those kidney labs are going to be abnormal. This also causes edema. We can get generalized edema, or like we talked about, facial edema, or in our hands, lower extremities, which is somewhat normal in pregnancy, but this could be amplified. And then we can also get pulmonary edema as well. And then we have decreased blood flow to the placenta. So now our baby is also being affected. The growth of the baby is being affected. Our baby can now be IUGR, which is intrauterine growth restriction. That placenta can come off of the uterine wall and detach or abrupt because of that decreased perfusion. And then baby obviously isn't getting enough oxygen, so fetal hypoxia. So this is a table from your book kind of breaking all of that down. So basically, mom's body has this reaction to the trophoblastic tissue in early pregnancy, the tissue that creates the placenta. That can cause generalized vasospasms. Those vasospasms can lead to endothelial damage of our blood vessels. And so then we can have abnormal clotting. And then we have small clots that can cause organ damage. Also, with those vasospasms, we have constriction. So we have a decrease in blood flow to those major organs that causes our blood pressure to go up, decrease oxygen to all of those major organs, including the placenta. That vasoconstriction also causes fluid to move out of the bloodstream and into those interstitial spaces, causing all of that edema. So there's a cascade of events that happens with preeclampsia, and there's varying degrees on the severity as well. Not everybody has all of these things. Okay, so how do we manage preeclampsia? So we have preeclampsia with severe features and without severe features. So that kind of helps us distinguish how aggressive we have to be with the management. So if they do not have severe features, which would mean they don't have really bad headaches. They don't have those visual changes. They don't have epigastric pain. Maybe they just have a slight little bit of protein in their urine and slight elevation to their blood pressures. If that's the case, then we just do more frequent monitoring of their blood pressure, their labs, their urine, more NSTs, BPPs. We're just watching them closer. And then we're probably going to recommend an induction once they get to 39 weeks, because at that point, we know that the baby's cooked, as they say, everything is developed, lungs are good, so it benefits more to just have that baby rather than put mom and baby at risk longer. Now, if mom has severe features, so she does have increasingly high blood pressure, she is having visual changes, terrible headaches, worsening edema, epigastric pain, her labs are being affected, elevated liver enzymes, issues with clotting, all of that, that would be severe features. That typically would necessitate delivery, depending on a whole bunch of different factors, but you're more likely to be induced early or have a C-section early if you're having severe features. You're going to be in the hospital, and then probably on magnesium sulfate for both of these at some point. You're going to have mag with this one at labor, but definitely if you have severe features, you're going to get magnesium. We're going to talk about magnesium again. And we'll talk about why that makes IOL as induction of labor, why that makes induction of labor more difficult. The only cure for preeclampsia, kind of like gestational hypertension, is to not be pregnant anymore, because the whole issue is the pregnancy. So delivery is the cure, but same thing, risks and benefits. What is more risky? What's more beneficial? We have to weigh that constantly. But eventually, once we deliver, it will cure that preeclampsia. Okay, so once again, magnesium. So we talked about magnesium from a standpoint of preterm labor. Now we're going to talk about it with preeclampsia. Same medication, very similar dosing, same side effects, same everything. So it's pretty much the same slide. So it is a CNS depressant and it blocks neuromuscular transmission to decrease seizures. We're using it in preeclampsia to protect mom's brain because we don't want her to have a seizure, which is called eclampsia, which we're going to learn about. We also want to, a side effect of that is that smooth muscle relaxation. So it does help with her blood pressure. It does typically bring the blood pressure down a little bit. But because it's relaxing the smooth muscle, if you think about with preterm labor, we don't want that woman to contract. So we like that side effect that it slows those contractions down. But when we have preeclampsia and we're talking about delivering, we want to get this baby out because that's the cure. So we're giving her MAG and it's relaxing her uterus, but we need the uterus to contract to get the baby out. So a lot of times it slows labor down. So we've got MAG that's slowing the labor down, and then we've got Pitocin over here that we're trying to get the uterus to contract to get this baby out. So we've got these two things fighting against each other, and that's why it can make labor more difficult, longer, and it's just really a pain in the butt, honestly. But we need that magnesium to protect mom from potentially having seizure activity. So our loading dose is normally 4 grams. It can go up to 6 grams. We do that quick bolus around 15 to 30 minutes, and then we slow it down to that maintenance rate of about 2 grams per hour. Same side effects, that flushing, that nausea, vomiting, just feeling really crummy. Therapeutic levels the same. Signs and symptoms of MAG toxicity are the same. Calcium gluconate is the antidote, so all of that is the same. And then typically our first sign of MAG toxicity is that decrease in DTRs and that change in level of consciousness. So you go in for your hourly assessment, can't really get her DTRs anymore, and she's really out of it, stop the MAG and get a MAG level. Okay, so what can happen with pre-eclampsia is eclampsia. So this is when mom does have a seizure. And this is a risk. Even on MAG, you can still have a seizure. So once mom has a seizure, it is now called eclampsia. So just like when anybody else has a seizure, our complications are injury. So head trauma, or, wherever she's at, she could fall out of bed, she could hit herself on the side rails of the bed. So a lot of times we will pad the bed with these padded rails. Also aspiration, so we want to make sure we've got suction at the bedside. We're going to monitor airway, breathing, circulation when a seizure is identified. We're going to try to place mom on her side. And then while we're doing all this, she's still pregnant. So we have to monitor that fetal heart rate because baby can also be affected. Also, we could have an abruption because of that force of the seizure and just everything we talked about with preeclampsia, that placenta can prematurely separate. So we have to watch that fetal heart rate, that contraction pattern. Also take care of mom. There's a lot of things going on at once. So a lot of people are going to be at the bedside doing all of these things to help you out. All right, something else that can transpire with preeclampsia and eclampsia is HELP syndrome. HELP is an acronym, and it stands for hemolysis, so the breakdown of red blood cells, elevated liver enzymes, and low platelets. So we have our labs are all over the place. Mom is not clotting well anymore. Her liver is really taking a hit. So even with preeclampsia, you have elevated liver enzymes. These are extremely elevated. And now we're breaking down our red blood cells. This is a variant of preeclampsia or eclampsia, and it occurs in about 20% of those individuals who have preeclampsia or pre-E with severe features. It can cause a lot of complications, and it typically comes on very suddenly. This is a very quick thing that can happen. Can cause cerebral hemorrhage, retinal detachment, rupture of the liver, DIC, where you can't clot any longer, or your clotting factors are severely affected, abruption, more seizure activity, renal failure, pulmonary edema, and death. So our pathophys is that abnormal vascular tone, that vasospasm, and then clotting defects. So it's like this cascading event of things. If you have HELP syndrome, we have to deliver. So this isn't kind of like a wait and see risks and benefits. At this point, it is way more risky for this person to stay pregnant. So a lot of times they will either get a C-section, or depending on kind of the severity of their labs and symptoms, they may be able to do an induction of labor. A friend of mine, she was an OB actually, she had HELP, and she was able to actually do an induction and have her son vaginally, but she was kind of right on the cusp. If she had taken any longer, she would have needed a C-section. So this is something, if you have HELP syndrome, that patient's going to be transferred to a tertiary center where they have, NICU, and they take care of high-risk patients. They're going to be on magnesium sulfate. They're probably going to need some blood products. So these are sick patients. This is just a little picture, just once again, reiterating everything. Okay, so antihypertensive medications. So we definitely use antihypertensives with our chronic hypertension, our gestational hypertension. With preeclampsia, we don't always use antihypertensives. It depends. So if they have kind of a mild range blood pressure, we don't want to mask that. And so a lot of times we won't treat that. And also, like, that's their normal blood pressure that their placenta is used to receiving that type of perfusion. So we don't want to like upset the balance. But if they have severe range blood pressures, we do give antihypertensive. So it's kind of difficult to like give you a direct answer. But here are some antihypertensives that we can use if indicated. So hydralazine, and usually it's an algorithm. You will start with, for the hospital I worked at, we started with hydralazine. We could give that, I think, twice. If that didn't help, then we would go to labetalol. So you follow your facility's algorithm. So hydralazine for us was the first line. So it is a smooth muscle relaxant. It's usually 5 to 10 milligrams IV push. Give that a few times per protocol, and then you would go ahead and go to labetalol. That's an alpha 1 and beta blocker. typical dose is 20 to 40 milligrams. It's also IV push every 15 minutes. And you're monitoring the blood pressure too per your protocol. So usually every 15 minutes or 10 minutes, 5 minutes, whatever it might be, you're rechecking their blood pressure to see if you need to go to the next step. And then nifedipine or Procardia, that's that calcium channel blocker that we also use for preterm labor. So you guys don't have to memorize the doses and everything. I just want you to recognize the names of these medications. And you probably already do from pharm. You know that these are antihypertensive medications. Okay, gestational diabetes. So this is diabetes that is diagnosed in pregnancy. So this is somebody who does not have diabetes, gets pregnant, and then develops diabetes. The cause is insulin inactivation by placental hormones. So we kind of talked about how the placenta kind of blocks that insulin activation and everything. So for some people, this is worse in their pregnancy for whatever reason. People are at higher risk for this happening to them. So those that are at higher risk would be those with obesity, chronic hypertension. If you have a history of kind of unexplained pregnancy losses, this could be an issue that you have is your blood sugars. Previous large baby, polyhydramnios, preeclampsia. If you have a strong family history of diabetes or history of baby having like a fetal anomaly, that could be like the underlying cause is high glucose levels. So complications, this does increase your risk of preeclampsia, increase your risk of infection like UTI or pyelonephritis, large babies, too much fluid, so polyhydramnios and preterm labor. For our babies, they are more likely to have issues with hypoglycemia, hypocalcemia, hyperbilirubinemia, so high bilirubin, premature birth, respiratory issues, stillbirth, and then birth injury. Because they are larger, they're more likely to have that shoulder dystocia. All right, so gestational diabetes diagnosis. So everyone throughout pregnancy gets a test for gestational diabetes unless they already have gestational diabetes, or I'm sorry, if they already have diabetes, then we're not going to test them for gestational diabetes. They already have diabetes. Or if they've had like a gastric bypass or something, like there's certain things that are contraindications, but for the most part, everyone gets screened for gestational diabetes. And that's done between 24 and 28 weeks. You get to drink this delicious little sugary drink called a glucola. And an hour later after drinking this, you get your blood checked and we check to see what your glucose level is. During that hour, you're not allowed to eat or drink anything, but prior to starting the test, you just eat like normal. So it's not a fasting test. If your level comes back elevated, and I'm not going to give you the levels because it depends on the physician and like the practice that you go to. They kind of change the levels that they use for diagnosis. But I'll just say if it comes back outside of their range, then they would order a 3-hour glucose test. So very similar test. You would drink that glucola again, but it's a glucola that has even more sugar in it. And then they check your blood sugar before starting the test. And then at 1 hour, 2 hours, and 3 hours. And that is a fasting test. So you would have to fast for at least 8 hours before that test. So it's 4 separate blood draws. And so if any one of those blood draws comes back outside of range, then that would get you the actual diagnosis of gestational diabetes. So the 1 hour is a screening test, and then the 3 hour is your diagnostic test. So, and I kind of down here, so 1 hour is a good screening tool for large groups of people, but it does have a high incidence of false positive rates. So that just means that more people are going to have to take the 3-hour test, but it kind of weeds out, some people. 3 hour has virtually 0 false positive rates. So it's a very effective test to say, okay, yes, this person does have gestational diabetes. The 3-hour test is difficult. It's difficult for anybody, but especially pregnant women, because I know I mentioned like not eating for a long time in pregnancy makes you feel really crummy. So when you're having to fast for 8 hours and then drink a whole bunch of sugar and then wait another 3 hours before you can eat something, you just feel like crap. So a lot of these patients just don't tolerate that test. They don't feel well. Sometimes they do get nauseous or even have vomiting. If you do vomit, unfortunately, you have to repeat the test. It's just a real pain in the butt. So I always tell my patients to bring a snack with them to eat right after that last blood draw. Once they get that fourth blood draw, eat that snack and try to keep that blood sugar from crashing down and making them feel even more crummy. But it's brutal. If our patient does get that gestational diabetes diagnosis, a lot of times we will coordinate our care with a diabetic educator, like a registered dietitian or somebody to kind of help with the teaching and the management and to go over like diet changes and things like that. Some people with gestational diabetes, it's just diet controlled, and others need oral medication and some need insulin. So it just depends. But we recommend a high protein diet and then slowly digestible carbs, no refined sugar. Blood sugar testing, it just really depends, but a lot of times it's about 4 times per day. And we do like our patients to keep a journal of their food intake and then their blood sugar readings. So there's your different treatment options. If you have a history of gestational diabetes, you are at higher risk for developing type 2 diabetes later in life. So diabetics, regardless of type 1, type 2, gestational, they do have a higher risk of having fetal malformations. It's 4 times the normal risk rate. And these babies are likely to be large babies. Macrosomic means a big baby, and so they're more prone to birth injuries or longer stalled labors. If you have diabetes, we like to deliver around 39 weeks, so a lot of times they will have an induction around that time. Just because of risks and benefits, it's more beneficial to deliver at that point. And that placenta typically doesn't work as well with diabetes. So we want to get that baby out before that placenta is really damaged. We do a lot more fetal surveillance and antenatal testing. So more NSTs, more BPPs, making sure they're doing those fetal kit counts. So monitoring how often that baby moves, calling us with any decreased fetal movement. That's always a really big thing. We're telling our patients, if your baby's not moving like normal, call us. That's a big red flag. And then blood sugar testing, making sure that they're testing their blood sugar throughout their pregnancy, and then in labor as well, we have to manage their blood sugar. So if they are on insulin, then we would manage their insulin during their labor. Okay, so then type 1 diabetes. So this would be like somebody who enters pregnancy already having type 1 diabetes. We already have that diagnosis. They already have like a management plan, but pregnancy can really jack up the insulin levels. So if they previously were really well controlled with their diabetes, pregnancy can mess that up. And so we really need to pair them with an endocrinologist, a dietitian, somebody to kind of help them with those fluctuations throughout the trimesters. Insulin levels can really change. So kind of the same thing, lots of fetal surveillance. We do recommend induction once they're term, lots of education. It's the same risks and everything. Okay, whew, this is a long PowerPoint. I'm so sorry. We are definitely not going to get through the other one. I kind of forgot how long this one was. Okay, torch infections. Okay, so torch is another acronym. These are certain things that if we're exposed to during pregnancy, we know that these can cause severe congenital anomalies, miscarriage, stillbirth. They disrupt the normal fetal development. So TORCH stands for, T is for toxoplasmosis. So toxoplasmosis, probably most of you have heard, but it's what you can get from kitty litter or cat feces. And so that's why when you're pregnant, they don't want you changing litter boxes. With that, is soil as well. You can get toxoplasmosis from like dirty soil. So if you're like gardening, you want to make sure that you're wearing gloves and washing your hands really well. I do have patients every once in a while that they don't have anybody else in their house that can change the litter box. You know, not everybody lives with somebody else, or maybe they only live with their like little kids. So the CDC recommends wearing gloves and then you know, changing the litter box and then washing your hands really well with soap and water. Some people will also wear a mask. You don't have to, according to the CDC, but so just trying our best to avoid that exposure. Toxoplasmosis is rare, but it can cause really severe defects of the developing fetus, so we want to avoid it. The O in TORCH stands for other, which includes lots of different things. It includes syphilis, HIV, varicella, so that would be like chickenpox or shingles, and then parvovirus. So any of those viruses, if it's like your primary exposure for like chickenpox or shingles or parvovirus, that can cause severe birth defects. If you've had the vaccine, like for shingles or chickenpox, then typically you're okay because you've got that immunity. But, syphilis, I already told you, we're always doing STI screening. HIV, we're always doing STI screening multiple times throughout pregnancy because we know that it's one of the TORCH infections. Rubella. So rubella is German measles. Most of us have had our MMR vaccine, but if you have not had that vaccine, or maybe you had the vaccine but don't have immunity, and you're exposed to someone with rubella, which is pretty rare, but can happen, then we know that that can cause severe birth defects as well. So rubella. Cytomegalovirus is for C, that's CMV. That's a common virus that most of us are exposed to as children, and we're, just fine, just like any other virus. But every once in a while, somebody gets to adulthood and they've never had CMV or never had exposure or created antibodies. And then they have an exposure during pregnancy and they have issues with that baby developing. My friend actually had that. Her first exposure was when she was in her 30s. I think she was 32. And so her baby on ultrasound was having issues with his organs in his abdomen. So he actually is okay and survived, but pretty miraculous that he did okay, actually. And then the H is for herpes simplex virus. So we talked about how if mom has a herpes outbreak during delivery and has a vaginal delivery, that the baby would then come into contact with that virus, and it can have pretty severe results. So those are your TORCH infections. So just kind of look over that, make sure you're familiar with those names and what TORCH stands for. Okay, and then a few slides on AIDS. So you guys, I'm sure, know a little bit about AIDS at least. So this is something that we've made huge advancements in, especially in the transmission from mom to baby. So a lot, like before we had more information in these medications, about 90% of our pediatric AIDS patients was from vertical transmission. Vertical transmission means mom to baby, so during pregnancy. And about 50% of those children that were infected with HIV at birth will get AIDS within the first year. So we've really cut down that transmission, that vertical transmission now, and we've reduced that all the way down to 2%. So that's amazing. We have all these antiviral medications. They're nasty meds, but they really do work and help to prevent that vertical transmission. We can be exposed to HIV through any kind of body fluid, so blood, semen, vaginal secretions, and breast milk. So we need to make sure that we have a patient who has AIDS, that she knows that she cannot, if she has HIV, that she cannot breastfeed. So we do HIV screening at the initial prenatal visit, usually between the second and third trimester, and then again at delivery. Because like I had mentioned when we talked about our STIs, it can take a while to show up in our serology, several months. So we want to make sure that we're checking at different parts in the woman's pregnancy in case she's had exposure at any points during that time period. I'm sorry, I'm switching back over here. Tony, you had asked, does the diabetes go away after birth if they have gestational diabetes? Yes, typically birth is what will fix it. The first couple weeks after postpartum, it will fix their diabetes. Now, some people do continue to have issues with their blood sugars, and then at that point, they would just be considered type 2 diabetic.
Okay,
Sorry.
thank you.
Yeah. Okay, let's see. So we talked about screening, presentation, HIV and pregnancy. So it's the same like testing that they use, that ELISA test or Western blot. There's like a couple different tests that they can use to actually make that diagnosis. But like I mentioned before, that seroconversion may not occur for 6 months after infection. So that's why we test multiple times. If we do have HIV, your immune system is obviously affected, so you're going to be more likely to have those opportunistic infections. And same with pregnancy, your immune system's lowered a little bit. So, things like yeast and herpes and other STIs, HPV. And then our management are those antiviral medications. So during pregnancy, that woman would take those antiviral medications. And a lot of times we are going to be pairing up with the high-risk doctor to manage this patient. So that would be your MFM, a maternal fetal medicine specialist. So that's like an OB doctor that did additional training to help with high-risk pregnancies. We also probably will have that patient see ID, which is infectious disease. So a separate set of doctors that specialize in infectious diseases. So a lot of different people in care of this patient. So our education, making sure that they are adhering to their medication regimen. It's a lot of different pills and they have kind of nasty side effects, but they do work very well. We give baby medications when they are born. I'm not super familiar with this because I didn't work on the newborn side, but I did have patients that had HIV during their pregnancy and during delivery. C-section delivery may decrease vertical transmission somewhat, and then we try to avoid any kind of invasive procedures until the baby has been born. So we talked about when babies are born, they're covered with, maternal secretions, vaginal secretions, blood, all of that. So we don't want to do any kind of invasive procedure and introduce that into the baby. So we would give the baby a bath and then do, circumcision or whatever it might be. Okay, a little bit about sickle cell anemia. So sickle cell is a genetic disorder related to abnormal hemoglobin molecules. So instead of being nice and round, they are sickle shaped. It is a chronic condition that's characterized by sickle cell crises. This definitely can complicate a pregnancy because it can decrease perfusion to mom's major organs, which would then affect blood flow to the baby. Our babies are also at risk for premature birth, growth issues, so small for gestational age, which is that SGA, and they also could inherit the disease or the trait. Our treatment is going to be trying to prevent those crises as much as we can. There are certain populations that are higher risk for having sickle cell. If they do have one of those high risk factors, then we can order a hemoglobin electrophoresis screen at the first prenatal visit, which is just a blood test to say if they have sickle cell disease or trait. If they have disease, they're going to know it already, but if they have sickle cell trait, that's just an important thing to know. Okay, so a little bit more here. So it can cause severe anemia. And we can have these vaso-occlusive crises. So we have these like little blood clots because those sickled red blood cells will kind of stick to each other. And so then it decreases the perfusion. This can cause issues with miscarriage, stillbirth, issues with placental abruption, development of preeclampsia, preterm labor, growth issues with the baby. Obviously, that's going to stress the baby out, low birth weight. So lots of different things here. Therapeutic management just really depends on the status, if this person's in crisis or not. A lot of supportive therapy, maybe blood transfusions, pain control is a really big one, and then antibiotics for infection. And oxygen also is another big one. Okay, heart disease. So we're not going to specifically talk about like any one type of heart disease, but just kind of like umbrella, some common conditions that a patient could have entering pregnancy: coronary heart disease, pulmonary hypertension, some type of congenital heart disease. We talked about all those cardiovascular changes in pregnancy and how they really peak at the end of the second trimester. And so that's a great risk period for these individuals during pregnancy. pregnancy, and then also during labor, just the taxing part of labor and how stressful that is, and then postpartum, all of those changes. So those are kind of the three riskiest periods of time for these individuals. Classifications of different cardiovascular diseases, they're either class 1 or 2, which have a pretty good prognosis for pregnancy. If your patient is class 3 or 4, that can make pregnancy much more risky and difficult and requires a lot more monitoring. They're probably going to spend a lot of time in the hospital and co-managed by a lot of different types of doctors. So this is just a reminder of the cardiovascular changes in pregnancy. So these are pretty significant changes, especially if somebody already has cardiovascular compromise. Okay, so what we may see in these patients, especially during pregnancy, during that 28 to 32 week, that's between second and third trimester, if your patient starts I can't talk anymore. Reporting shortness of breath on exertion or dyspnea. So just kind of any difficult breathing or even at rest if they're having difficulty breathing, when they lay down if they're having difficulty breathing. Of course, if they're experiencing any kind of cyanosis, any kind of swelling in their face, hands, or feet, if they have any kind of jugular vein engorgement, rapid respirations, abnormal heartbeats or like heart palpitations, racing heart, chest pain, any kind of lightheaded, dizzy, or if they do pass out, increased fatigue, and then if they have a moist, frequent cough, like a wet cough. So those are all things we need to really ask about and assess for, and just have really good assessment skills because these people are really high risk. We can treat with diuretics like Lasix, beta blockers like labetalol, calcium channel blockers like Procardia or nifedipine, anticoagulants like heparin, but we do not use Coumadin or warfarin in pregnancy because it can cause issues with fetal development. So we use heparin. So this is, like I said, a team approach. So a lot of times we have our maternal fetal medicine, our high risk doctor, we have our cardiologist, we have our regular OB, our labor nurses, maybe NICU is involved. A lot of times they're on a cardiac monitor while they're in the hospital. So either we as labor nurses read that cardiac monitor or telemetry monitors. It depends on the facility you work at. So lots of different people watching over this patient. Our management during pregnancy, activity is tolerated, rest, monitor for any of those like signs and symptoms, making sure they're on their medications. And then during labor and postpartum, we're going to try to avoid laying them flat, try to weigh in the benefits to like a vaginal delivery versus a C-section delivery, which one's riskier, pain control options, watching for hemorrhage, and then cardiac monitoring, vital signs, and then of course, continuous fetal monitoring as well. All right, teen pregnancy. So obviously lots of issues that can come about with a teen pregnancy. Let me see here. So kind of developmental tasks. You guys haven't had peds yet, but obviously just from being a teen yourself, you're growing up trying to figure out things, and then also now you're trying to figure out how to be a parent as well. So those are very conflicting states to be in. So typically teens are, self-involved and don't always connect their actions with consequences, and so they just may have more issues kind of caring for a baby and giving up that part of their life to care for the baby. So that's understandable. They are at risk for preterm labor, or more at risk for preterm labor in small babies. Usually they don't get great prenatal care, or they're late to prenatal care, or, they just don't really accept that they're pregnant and don't get any prenatal care at all and show up when they're in labor. I've seen that quite a few times. They may have poor weight gain. And a lot of the times their relationships with the father of the baby don't last the entire pregnancy, or maybe it's not a great relationship, or maybe they don't have a great relationship with their family. There's just a lot of different social issues to consider. STIs or STDs may also be an issue. Substance use can be, and then neglect and battery may also be at higher risk. And then advanced maternal age, or AMA. So older individuals. So if you're 35 years or older, and so even if you're like 34 when you get pregnant, if you will be turning 35 during that pregnancy, you are considered AMA, or advanced maternal age. So we're at risk for, I say we, because I'm AMA, we're at risk for developing gestational diabetes, preeclampsia, labor dystocia, like an abnormal labor, preterm labor, hemorrhage, low birth weights, chromosomal abnormalities, more likely to have, so the older you are, the more likely you are to have chronic conditions already. So you're entering pregnancy already having hypertension, already having diabetes, and now you're pregnant. And it just depends on the person. Okay, whew, we're done. Oh my goodness. Longest PowerPoint. Okay, let me go ahead and finish up here with chapter 21. So this will cover the actual like labor and birth process again, but now we're going to talk about some of the things that can go wrong, unfortunately. So, all right, first thing we're going to talk about is dysfunctional labor, which you may also see as dystocia. I think that's a little confusing because we're going to talk about something called shoulder dystocia. So seeing that word in a different context is kind of confusing. So I usually just say like a dysfunctional labor. I don't really call it dystocia, but your book mentions that, so I just wanted to include it. So basically, a dysfunctional labor is where we have some issue with that cervical effacement or dilation or the descent of the baby down into the pelvis. So usually it's kind of a combination of those factors. And there's lots of different things that can cause those issues. And we have issues with, when we talk about the P's of labor, we can have issues with the powers. And remember, the powers are like the contractions or mom's like force to push the baby. Those can also affect our labor. So we can have different types of labor in terms of the contractions themselves. So they can be hypertonic, which is where we have lots and lots and lots of contractions, or hypotonic, where we don't have enough contractions, or they're just like really wimpy contractions, like more of like an irritability. They're not really doing a lot. They're not effective. So let's talk about that hypertonic. So if we have contractions that are back to back to back, that means that the uterus doesn't get to fully relax. And so we don't have those periods of rest to where that placenta is able to get reperfused and mom gets a break from the pain of the contractions, baby gets reoxygenated. There's just not enough time because then the next contraction is right after the previous one. And sometimes these contractions can be ineffectual or erratic or poorly coordinated. So we can have something like coupling, where you have two contractions back to back, a space, two contractions back to back, a space. So it all just kind of depends on the scenario and that patient. But for whatever reason, the uterus is not contracting and resting appropriately. So our risks would be poor placental perfusion, maternal exhaustion, and then this can cause a prolonged labor if there's just a lot of contractions, but they're just not strong enough, or a precipitous labor if the contractions are back to back and they are strong contractions. I would say that that's what I experienced. I had contractions that were about every 1.5 minutes, and they were very strong, and so that caused, that would cause my baby to be pushed down on my cervix, and then it dilated very quickly, effaced very quickly, and then I delivered very quickly. So that's a precipitous labor, very fast. So our management with these hypertonic patterns would be rest, hydration. Maybe if it's somebody who has a bunch of like little crampy contractions and they're just exhausted because they're not really doing anything, but they're happening so frequently that they can't really rest. So maybe we need to give them some type of medication to help them rest. So that's the sedation aspect. So maybe like a little Ambien or something like that to allow them to rest. We can also give them some medication to make those contractions stronger, so like Pitocin. Sometimes when we add some Pitocin, it seems silly, but it actually helps to space out those little contractions and just make them more effective. So you have like one big contraction, it spaces out, big contraction, spaces out. So it kind of gets you into a better pattern. It seems like it wouldn't, but it does. Or we can break their water. Sometimes that also will kind of like kickstart things into a better pattern. Or if it's the opposite, where we have those contractions that are back to back, but they're really strong and maybe they're causing issues with mom or baby, we can give a tocolytic. Tocolytic is like that medication, that terbutaline or Terb, to slow down those contractions. And that way we have a chance for mom to take a break and that placenta to take a break. So it really depends on the scenario, kind of what your management strategy is. So here's a example. So here's that coupling that I was talking about. So you have these contractions that are back to back. You've got a space, and then here we've got 3 that are back to back. And you'll notice like between these 3, after this one, it doesn't really come back down to the resting tone. It kind of is halfway into that contraction and another one starts. So the uterus is just really erratic. It's just not functioning well. And over here, you just see these hypertonic back to back to back to back, very little space at all in between these contractions. And right now the baby is handling that pretty well, but over time that baby will get very stressed out by that. Okay, and so then hypotonic, these would be contractions that are poor in quality or like poor in intensity, and they are not dilating and effacing the cervix. So they're just wimpy, basically. So some things that can cause this would be if we have an overstretched uterus, maybe from twins or polyhydramnios, and the uterus just can't effectively contract down, so it does these like little pulses, basically. Or maybe we have bowel or bladder distension that's preventing that descent. So we have like a blockage, basically. So maybe their bladder is really full or their bowels are really full, and it's preventing everything from kind of moving down. Risk could be exhaustion, maternal exhaustion from a long, ineffective labor, or hemorrhage because that uterus can't effectively clamp down. And so then it's boggy and it's bleeding. So management, kind of the same thing, rest, hydration, sedation, just depends on the whole scenario, and Pitocin again. So kind of the same thing, that we need to get these contractions to be stronger. But for this scenario, it would make them closer together. So it's just funny that you use these same techniques, but it has like a different effect depending on the situation. So here's kind of what that hypotonic can look like. So you've got contractions that are just kind of wimpy, and then more of like an irritability. So they just kind of, the uterus tightens a little bit and then loosens up, tightens a little and loosens up. So it's not really doing a whole lot. Okay, so precipitous delivery, I just mentioned this, but this would be defined as a labor and delivery less than 3 hours from start to finish. So what can cause this? The more babies you have, so multiparity, typically the quicker your labor and delivery process goes. If you have a smaller baby, that can also make things quicker. And then if you had a previous precipitous delivery, you're more likely to have another one. Risk could be trauma, like trauma to the perineum, just because everything just happens so quick, things don't get a chance to stretch out. Birth injury, just from how quick things are happening, babies can come out pretty bruised. And then hemorrhage, so that uterus has a tough time clamping down afterwards. So our nursing implications, just be vigilant. Always be ready to catch a baby, because this can happen to anybody. It can be very overwhelming to the patient, and the baby also has kind of a difficult transition because they're kind of shocked. Because truly this can happen within, a couple of moments or maybe an hour. The baby hasn't really had a chance to make those slow transitions and that slow descent into the the pelvis. So it's overwhelming for everybody. Pain meds can help, but just remember that we have to be careful with any kind of IV pain meds. If mom is progressing really quickly, then we can't give her IV pain meds because baby could have respiratory depression from those medications if it were to deliver quickly. And then, like I had mentioned, baby may be bruised. This does resolve, but they can just look a little beat up at first, and usually they don't have any molding. So their head is perfectly round because it didn't sit in the pelvis long enough for those bones to even shift or shape differently. All right, other forms of dystocia. So we can have this is kind of back to those phases that we talked about. So prolonged latent phase. So latent phase are those first few centimeters. The new definition is from, start of labor until about 6 centimeters is your latent phase. Or you could have a protracted or prolonged active phase that would be 6 centimeters to 10 centimeters. You could have a rest of descent. So the baby doesn't continue coming down. So maybe they're kind of stuck at that 0 station or stuck at that -1 station. So for whatever reason, they're having trouble dropping down farther into the pelvis. Anytime a labor exceeds normal limits, then we're going to have risks of maternal exhaustion and then distress of the baby. So the interventions are going to be, making sure mom is well hydrated, and if she needs to take a break from everything and have a meal, if she needs to rest, doing lots of position changes. I know I mentioned that before. So important to move our moms side to side and sit her up and get her in a squatting position, whatever we can do, because that helps the baby descend into the pelvis. And then sometimes if she is on Pitocin, we have to take breaks from that Pitocin. Those Pitocin receptors can get flooded basically, and so then the Pitocin can no longer really work. And so we can stop the Pitocin, kind of clear it out of her system and start over again, and that can really help. Okay, so we can also have problems with our passenger or our baby, which could contribute to having this dysfunctional labor. So if we think of things like a really big baby, like a macrosomic baby, that's a big baby, that can obviously cause issues with them making their way down into the birth canal. Also those fetal positions. So we talked about that OP, that occiput posterior or sunny side up, changes the diameter of the head into the pelvis and making it more difficult to birth. Compound presentation. So that would be like maybe baby has their hand up by their head. That takes up space, changes the diameter, and they're not able to make those rotations, or a breech baby. Shoulder dystocia, which we'll talk about. A multi-fetal pregnancy, so twins or more, and then any kind of like anomaly, things like a tumor, if baby has a tumor, or a large skull for whatever reason. So there's lots of different things that can change the baby's anatomy, making it more difficult for them to make that rotation into the birth canal. So here's an example of a compound. So this baby's got its hand. I actually checked someone's cervix one time and they had a compound hand presentation and the baby grabbed my finger. That was very bizarre. Wasn't expecting that when I was checking a cervix. So luckily with that patient, the doctor was able to push that hand back in and she was able to deliver vaginally. But a lot of times when you have a compound presentation, it's kind of stuck there, like the baby has gone down far enough to where we can't move that hand safely back up. And so we would have to do a C-section. And then here's kind of showing you the difference between that OA and OP. So remember, occiput is the back of the head. This is the front of mom. So occiput anterior versus OP. So the biggest part of the head, which is the occiput, is putting more pressure on mom's back and rectum. And it also changes the diameter of the skull, making it larger. And then there's your breech positions again. So there's your complete or like cannonball looking position. Here's your frank breech where they're hugging their feet to their head, and then footling, which can be single or double. This happens more often with our preterm babies because most babies do start out in a breech position and then they will turn when they get further along. About only 3% of term babies are breech. So causes of a breech presentation, so prematurity, polyhydramnios, so the more fluid you have, then the more space that baby has to be able to get into different positions. Some head malformations, placental position, so depending on where that placenta is, it can limit how baby can move. Uterine anomalies, so some people have like a septum in their uterus or maybe a total separate part of their uterus. So that can change how much space the baby has and availability for them to turn. So risks would be maternal soft injury issue. So like during the delivery process of a breech delivery, prolonged labor, C-section, like they're more likely to have a C-section. And then really what we worry about is that entrapment of the fetal head. So the head is the largest part of the baby. So if the rest of the body comes out and then we just need the head to come out, it can get stuck on the cervix. Management, so normally we have ultrasound to confirm the position. Sometimes we can rotate these babies while in utero, and that's that ECV or external cephalic version. You have to meet certain criteria to be a good candidate for that. But if you are, then they can try to rotate baby into a head down or vertex position. Typically here in the United States, we do mostly C-sections for our breech babies, but it depends on the hospital that you work at. I have seen quite a few breech deliveries, but at a hospital that doesn't have as many resources, a lot of times they're going to be a C-section. And other countries also will do breech vaginal deliveries. Nursing implications. So when we talked about kind of figuring out the position the baby's in and where to put like our Doppler, if we are finding our fetal heart tones above mom's umbilicus, above her belly button, that's suspicious for a breech baby. And then also we are concerned with when her water breaks that she's more at risk for a prolapse cord because that head isn't sitting down there plugging the cervix. And so sometimes that umbilical cord has a chance to go down in the cervix and fall through when the water breaks. And then we're in a real big pickle. So we'll talk about prolapse cord here in a bit. And then shoulder presentation or that transverse presentation. So causes of that would be, the more babies you have, if you have multiple gestations, so twins, triplets, premature babies have more space to move, placenta previa, polyhydramnios, so kind of some of the same things. Management, we can try that ECV or external cephalic version to try to flip them or turn them, or C-section. So our nursing implications, so we can feel this if we do Leopold's by palpating the abdomen. This definitely feels a lot different than a baby that is up and down. And then same thing, babies are at risk for dropping that cord. There's extra space down here so that umbilical cord can slip on down. This is just kind of showing you this is not what a version looks like, but just illustrating that we try to flip the baby head down. And then we can also have face or brow presentations. So we can diagnose this with ultrasound or when we do our SVE or sterile vaginal exam, and we, have our fingers through the cervix, we can feel the baby's face. So we would diagnose it that way as well. Typically, if we have a face presentation, it's going to be a C-section or even a brow presentation just because that diameter is so much larger. It's just really difficult to deliver vaginally. However, I did find this picture online, which I thought was so cool and traumatizing. This baby is a face presentation coming out vaginally, which I have never seen before. I just think that is such a wild picture. And currently her perineum is intact, which is pretty amazing. So I don't know if any of you will ever see something like that because, I've had babies that were face presentation, but they always went to C-section. So all right. And then we can also have problems of the passageway or the pelvic. So we talked about the different pelvic shapes. So if somebody has a smaller pelvis or maybe a different shape than like a gynecoid, that can obviously slow labor down, or babies can kind of get stuck in there. We can have that really big baby that gets stuck in the pelvis. That's that CPD, that cephalopelvic disproportion. So small pelvis, big baby gets stuck. And then we can have soft tissue obstruction. So like I said, if mom's got a really full bladder or really full bowels, that takes up space, and we need every little centimeter of space that we can get. So what we can do about that, at least, is making sure that we're assessing her bladder and emptying it. Either if she doesn't have any kind of anesthesia, she's getting up every 1 to 2 hours, or if she has a epidural or spinal or something that she has, we're either straight cathing her or she has a Foley. So there's your different pelvic shapes. Remember, gynecoid is the preferred pelvis for vaginal delivery and the most common female pelvis. And then we can have problems with the psyche. So we talked about how our perception of the labor process and our pain management strategies and our pain tolerance and what kind of support system that we have, what kind of horror stories that we've heard. All of those things can cause us to kind of tense up and kind of go against our body's natural like labor process. Some women, this is really a terrifying ordeal or very painful. And so they kind of go into that fight or flight response. That can increase their pain perception or decrease their pain tolerance. They tighten all their muscles, and they're in this stress state now. So all of that can make labor way more difficult and longer. All right, so our post-term pregnancy, we kind of talked about this already, but so one that lasts longer than 42 weeks, and we worry about that placenta function, we worry about meconium aspiration, we worry about really big babies and that birth trauma. So just lots of different things. We've already covered most of that. Polyhydramnios, we kind of covered this already too. So those risk factors would be diabetic mothers, multiple gestation. This NTD is neural tube defects. So things like spina bifida. If baby has any kind of GI or kidney abnormalities, that can increase the fluid because amniotic fluid is made up of fetal urine. And then labor considerations, you're at risk for preterm labor if you have polyhydramnios, hypotonic contractions because the uterus can't contract effectively, and then that prolapse cord. And then oligo, so not enough amniotic fluid. Causes could be anomalies with the baby, maybe mom's got hypertension or inadequate weight gain, or it's a post-dates pregnancy. Eventually we start running out of that amniotic fluid and we don't make any more. So risks of stillbirth, meconium aspiration, distress, some type of malformation, and then C-section. And then our labor considerations, we talked about how sometimes they'll do an amnio infusion, and then we're just really watching that fetal heart rate. Meconium stained amniotic fluid. So this is where baby does have that bowel movement in utero. So this is typically a sign of a baby who's not getting enough oxygen and is distressed. Meconium is that first bowel movement. It's really thick. It's kind of a green, blackish color, kind of like tar. It's very, very sticky. And so when baby is born, if they do inhale that, it can block their airway. And so then they're not able to have any kind of gas exchange. So it can be very, very dangerous. It can also lead to infection. So if we do have a really bad case of meconium and baby does get a big gulp of that, sometimes those babies immediately need to be intubated, and then they could actually suction out as much of that meconium as they can, but normally that baby would spend some time in the NICU, be on antibiotics and monitors and everything. And then placental abnormalities that we briefly, I think, talked about this, how the placenta can attach too deeply into the uterine wall, and there's different variations of this as well. So if it's attached too deeply, then at the time postpartum when the placenta is supposed to come out, it has trouble separating, and sometimes it's not able to separate. So our normal is right here. Underneath that is an accreta, so it's just a little bit farther into like the muscle. And then increta is completely into the uterine muscle, and a percreta is through the muscle and through the uterus. So it is like taking over inside of the abdomen at that point. I don't know if I've ever seen a percreta. I've definitely seen accreta and increta. So what can happen with any of these is that the placenta isn't able to detach, and so the uterus cannot clamp down effectively, and so the woman starts to bleed and hemorrhage, and sometimes they have to actually remove the uterus to get control of that bleeding. So anybody with a placental abnormality like this is at risk for a hysterectomy. All right, and then umbilical cord prolapse, we've mentioned this about 1,000 times, but the prolapsed cord is when the water breaks, so the sac around the baby opens up, fluid comes out, and that cord, umbilical cord, slips down through the cervix before the baby, and so then the baby comes down afterwards and kind of makes like a cork, a plug, and then it's compressing that umbilical cord, and baby is no longer receiving any kind of oxygen. So this is something that happens very quickly. It has to be recognized very quickly, and we need to rush that patient back to the operating room within minutes because we truly just have minutes before that baby will die. So what our primary intervention as nurses is if we are the ones to see this or find this, we have to check the woman's cervix. And when we feel that umbilical cord, you can feel it. It may still be pulsating if it does have some perfusion, or it may not be. You have to push that presenting part. So head, butt, whatever is down there of the baby, you have to push it as high up as you can get it to try to relieve that pressure on the umbilical cord to restore normal blood flow. And then you have to leave your hand there until that baby is cut out. So you will ride that bed back to the operating room. They will drape the surgical drapes over you. They will put the woman to sleep. They will splash betadine on her abdomen. Meanwhile, you're under the drapes holding whatever it is up above the umbilical cord. And then they will use a scalpel to cut through all of the different layers, and they will remove the baby, and they will be able to see your hand inside the uterus at that point, or inside the cervix into the uterus. It's pretty crazy. But they have to do all of that within a couple of minutes, or else baby will have brain damage or pass away from lack of oxygen. So it is an OB emergency. So there's different types of prolapse cords. So it can be, this is occult, it's like hidden kind of inside the uterus. So this is something that we can't like see or feel. There's nothing really that we could do about that. Like if we wouldn't have a way to know that that's what's going on, basically. Whereas like a complete or a visible, these are things that we can feel. Like this one we could feel, and this one we would actually be able to see. Like you could look at someone's vagina and it was already like coming out the vagina. Whereas like this one here, you're checking their cervix and you can feel the cord. All right, so our risk factors would be any kind of abnormal presentation, multiple gestation, so twins or more, there's going to be more than one umbilical cord, so more chances that one of those cords could drop. Rupture of membranes with unengaged head. So if the water breaks before the baby is engaged in the pelvis, remember engaged is 0 station. So if the baby's above that and the baby's still ballotable, remember ballotable means it can bounce up and down. It's not engaged in the pelvis. There's more of a risk that that cord can fall down and then the head will drop over the cord. And then polyhydramnios, so lots of fluid. What we may see that would give us like some red flags is we would see on our monitor variable D cells, which are cord compression, that are getting deeper and deeper and wider and more frequent. And then decreased variability. So gradually that baby is not going to be handling that well. And so that variability is going to go away. We're going to see that minimal variability or absent variability. And then bradycardia, where just that heart rate's just going to plummet and not be able to come back up. So variables really is what we need. If we're seeing a lot of variables, our first intervention should be to check her cervix to make sure that that's not what's going on. So if found, if we are the ones to find this on our sterile vaginal exam, you cannot remove your hand and you have to push that presenting part off of the cord. So you have to push it up. After you've done that, or simultaneously, you're going to call for help. So you're going to either, if you have a Vocera, if you have a phone, if you have a call light, if you have an emergency button, you may need help from your patient. Hey, push your call light, or the support person. Hey, go into the hallway and yell, I need help, whatever it is, whatever you can do to get help there immediately. And then this is prepare for stat C-section. If you are the one with your hand in the vagina, there's nothing that you can do to prepare. So all you're doing is giving report, basically. As everybody comes in, you're telling them the pertinent information, and then everyone around you is preparing for that C-section. So the people around you can give breathine or terbutaline to slow down contractions, kind of get rid of that compression, put oxygen on mom. If you can get the patient in a different position, like a knee chest position, that is something. We never did that because we just ran back to the operating room. So that was what we needed. That was the quickest thing. We just needed to get to the OR. We didn't really want to waste time by changing positions, but maybe if you're in a birthing center or something like that, that's something that you could try, or you may see in your textbook or somewhere like Trendelenburg. That's also like something just to like change the gravity, but I would say in practice, that's not something that we do because we don't want to waste time doing that. We want to get back to the OR for delivery. So let's talk about shoulder dystocia. This is also one I've mentioned here and there. This is another OB emergency. This is about 1% of all births. And this is where the fetal shoulder, so the head starts to come out, and then the shoulder, that anterior or top shoulder, gets stuck at that pubic bone, at the symphysis pubis. So risk factors would be our big babies, which we know can happen with diabetes. So maternal diabetes, which causes macrosomia, puts you at risk for shoulder dystocia. Maternal obesity, because we can have fat dystocia. And then post-term, so just bigger babies. We are going to suspect a shoulder dystocia if we have a prolonged labor and a long second stage. Second stage is when mom is pushing. So she's pushing and pushing and pushing, and she's just not making a lot of progress, and that head is just really not coming down. Or if our estimated fetal weight is more than 1 pound larger than her previous baby. So maybe her first baby was, a little 6 pound baby, and this one is estimated to be an 8 pound baby. That's a big difference. If she's had a previous shoulder dystocia, then she's definitely at risk for another. And then there's something called turtle sign that we can see. So when we are pushing and we get to the point where we can see the head will come out a little bit and go back in. Go out, come back in. So some of that is part of normal labor, that like rocking back and forth. But it's just not improving. It's just staying right there. We're not making any more progress. So that's turtle sign. So some potential complications. So we can have injury to mom. So those could be more lacerations, or a lot of times the provider will have to cut an episiotomy to make more room. Depending on the position that the baby's in, we could have injury to the bladder, we could have a hematoma. All that increased pressure can cause uterine rupture, hemorrhage, and then our baby can have injury to its actual body. So the shoulder is stuck under that pubic bone, and then the head is getting pulled and the neck is getting pulled, and we have a bundle of nerves that run from the head down the arm on each side. That's called your brachial plexus. So if that's getting pulled too much, it can actually damage those nerves and cause paralysis on that side of the baby's body. We could also have fractures. So oftentimes the baby's clavicle will break because it gets stuck, or the provider may intentionally break the clavicle in order to allow that shoulder to collapse in to give space. So better to have a broken clavicle than a brain dead baby. I know that sounds really harsh, but it's very true. They also, the provider can break the baby's humerus as well. Pretty difficult to do that, but they can, to create any space that they can to get that baby out. And then of course, if we are still still struggling, baby's gonna lack oxygen during this time and can pass away. These are really scary because shoulder dystocias, you get to a point where there's nothing else that you can do. There's a lot of different maneuvers that we do initially, and there's maneuvers that the physician does. So I'm going to talk about, as nurses, what we can do, and then what the doctor does, we don't really go into, but if you end up being a labor nurse, you'll kind of learn all of that. But there's certain things that they're doing while you're doing your maneuvers, and you're kind of working together. The last ditch effort is what's called Zavanelli's maneuver. I've never seen Zavanelli's, and any of the OBs I've worked with, I don't know any that's actually done Zavanelli's, but that's where it gets to the point where they've exhausted all of their options. Nursing has exhausted all of their options. And so the only thing left is to take the baby and shove the head back up through the cervix back into the uterus, and then go back for a C-section to deliver. Oftentimes at that point, the baby has passed away, or will be, severely neurologically affected. So very rarely, like I said, I have never had any experience with Zavanelli's, but at some point that baby has to come out, and if we can't get it out vaginally, then that would be the option. So here's just a little picture to kind of show you what's happening. So you've got your baby's head that has come out, but the rest of the body cannot come out because this anterior or top shoulder is stuck on the pubic symphysis. So when we are doing our maneuvers as nurses, we try to pull mom's legs back towards her chest. So we bend at the knee, kind of like that pushing position, but we pull those legs back as far as we can get them to where her knees are almost touching her ears. That's called McRoberts. I'll show you all this, but, and that helps to tilt this part of her pelvis up a little bit, and it increases the pelvic opening. And sometimes that's all it takes. That little centimeter of change helps to release that shoulder. We can also do something called suprapubic pressure. So supra means on top, pubic, and then pressure. So we take our fist and we push down on this area right where the shoulder is stuck, and we're pushing down on the shoulder to get it to go into the baby's chest and kind of release it underneath that pubic bone. When you're doing suprapubic, you want to be behind the baby, because you don't want to be the person pushing this way and then the shoulder's getting more stuck. You want to be behind the baby to push the shoulder into the baby's chest, if that makes sense. It's a little bit easier in lab when I can show you guys, or Nicole can show you guys what that looks like, but got to be behind the baby to do suprapubic. So a lot of times, if you have worry that this patient may have a shoulder dystocia, you have two nurses in the room and you each stand on one side of the bed because you don't know which way the baby's going to come out facing. Once it's identified, then the person that's behind the baby will do the suprapubic pressure. Okay, so here's our maneuver. So the first thing we're going to do when we recognize a shoulder dystocia is lay the bed flat. Oftentimes we're in kind of like a, maybe not semi-Fowler's, but definitely not, bed's not flat when we're delivering. But when we're going to do these maneuvers, we want the bed flat because it opens the pelvis up and it gives us a little more space. So the first thing is that McRoberts maneuver. That's that hyperflexed thighs to widen the pelvic outlet. So bring her legs all the way back. And then suprapubic pressure. So firm downward pressure above the pubic bone to try to rotate that anterior shoulder. Oftentimes you need to stand on a stool. I always just climbed on the bed, but most labor rooms will have a stool for this very reason. There should always be a stool available in case there's a shoulder dystocia. For me, I never wanted to mess with trying to grab the stool and figure out which side of the bed to get it on, so I just climbed in the bed. While you are doing your maneuvers, like I said, the provider is doing theirs. So they may be trying to rotate the baby, rotate the shoulders. They might be trying to deliver that other shoulder, the posterior shoulder. So it takes communication with the provider. You don't want to be pushing down, doing suprapubic pressure while they're trying to deliver the posterior shoulder. So they may tell you to stop while they're doing something and then start again. So just really make sure the room is quiet and you can communicate. Also, what we're doing, I don't know if I have this on a different slide, is we're timing this shoulder dystocia also. So once it's recognized, there should be a timer in every single labor room that you hit the start button, or somebody hits the start button, or you look at the clock, because you need to know how long this is happening so you can account for the time that the baby is going without oxygen. And then, like I said, the provider may have to break clavicles, or the humerus may have to cut an episiotomy. Okay, so here's your McRoberts. So these nurses are going to pull this woman's legs back to where her knees are all the way to her chest. And that helps to change the diameter of the pelvic outlet. So you can see how much that changes. And then here we're doing suprapubic. So this nurse is behind the baby and it's pushing, or they're pushing right above the pubic symphysis bone and trying to push that anterior shoulder forward. Okay, so may need episiotomy. They also want the bladder emptied, so you need to hand a straight cath over because we don't want any kind of full bladder like taking up space. Once help arrives, because if you do have a shoulder dystocia, you're going to call out for extra help. You're going to make sure that everybody knows what's going on and they need to be ready for a full scale resuscitation in case this shoulder dystocia lasts, several minutes. That baby's going to be affected. And then a lot of times this woman will also have a hemorrhage from all this trauma and pressure. So we need to have a hemorrhage kit in the room, which includes Pitocin and a medication called Methergin. There's also Hemabate and Cytotec. So we have like a hemorrhage kit that's already put together that we can grab quickly and bring to deliveries. And then, must keep track of time. So we have a timer, and then take direction from the provider. So having that communication, keeping the room quiet, and being able to hear what everyone needs and is doing. Okay. Let's talk about induction and augmentation. So induction of labor, or kind of artificially the initiation of labor. So somebody who's not in labor, that we're going to get them in labor, is kind of like that risks and benefits thing that we keep talking about. So if it benefits, we have more benefits for delivery than we do to keep her pregnant, then we're going to do an induction. And we also are not going to do an induction if a vaginal birth is not safe. So, if baby's already compromised, or if she has a placenta previa or something like that, we're not going to induce her labor. We're going to go for a C-section. So our medical indications for induction, and also augmentation, means that somebody who presented in labor and it has stalled out for some reason, and so we augment, we give something to make that labor kind of kick back up or keep going. So that's augment. So medical indications would be some type of issue with the growth of the baby. So maybe the baby's not growing well, or maybe there's like RH incompatibility, or something with the baby is telling us, okay, this baby would do better in the NICU than it would in the uterus. If we have spontaneous rupture of membranes and we are close to being term, a post-term pregnancy, if mom has an infection like chorioamnionitis, hypertensive disorders, gestational diabetes, certain medical conditions that mom may have, and then if we have a demise, a fetal demise. So these are all just some medical reasons that an induction may be indicated. There is something called the Bishop's score, and it is a way that we can kind of assess that woman's cervix to see how ready she is for labor. So it measures certain things about the cervix, and then we kind of tally up a number, and it lets us know, like, okay, she's a good candidate for induction. She'll probably be able to have a successful vaginal delivery. It also lets us know, like, do we need to start this induction with cervical ripening? Remember, cervical ripening is medication that we give to kind of soften the cervix and get it ready for Pitocin. So if your cervix is like, if you've done nothing in your pregnancy as far as like your cervix, it's still closed, it's still really thick. Baby's still really high up there. The cervix is hard. And we just give you Pitocin. A lot of times that Pitocin isn't going to do anything. So we have to give another medication to kind of get the cervix ready. So that's cervical ripening. So our Bishop score helps us figure out if they need that cervical ripening. So here's a Bishop score, so you kind of know what they're measuring. So we check a cervix, and then depending on the dilation, the position of the cervix within the pelvis, the effacement of the cervix, the station of the baby, and then the consistency of the cervix, we can add up our score over here. And then depending on the number, the higher the score, the more ready that person is for labor and more likelihood that they'll have a successful vaginal delivery. Okay, so with our induction or augmentation, any contraindication to labor or a vaginal birth is going to be a contraindication for induction. So like I already mentioned, if they have a placenta previa, we're not going to induce their labor knowing that they have to have a C-section. If they have a vasa previa is where that umbilical cord has an abnormal attachment to the placenta, like a velamentous insertion, and then we have these the vein and the arteries connect over the amniotic sac inappropriately, and then that part is like over the cervix, and then if her water breaks, it would break all of those vessels and cause mass amounts of bleeding. So if we know she has a vasa previa, she can't have a vaginal delivery. If we know that this baby's in a transverse position, like a shoulder presentation, we're not going to make her go into labor. If we have a cord prolapse, we're not going to induce her labor. There are certain uterine scars. So if she has a vertical scar on her uterus, we would not induce that person or augment that labor because we don't, that uterus is already scarred and it's already at risk for rupturing or opening up. So we don't want to give medications to make that risk even higher. If baby has non-reassuring fetal heart tone, so if we're already seeing D cells, we're not going to add more stressors like Pitocin. We're going to go do a C-section, and then active HSV infection. So our risks for induction or augmentation, so we have our normal risks of delivery, plus now we are adding, a stressor. We're adding Pitocin or some type of medication that's affecting the uterus. So we can end up giving too much or having a uterus that's really sensitive to medications, and then we can get into a hyperstimulation, so too many contractions, where we gave Pitocin, and for whatever reason, this mom reacted more to that Pitocin. I feel like I'm one of those people that if I get like a whiff of Pitocin in the air, my uterus starts contracting. So we just have to be careful with that because too many contractions, we know, decreases fetal oxygenation. And then if our uterus is stressed out and over contracting, then we can have uterine rupture where it actually opens up, which we will talk about. Pitocin also can cause maternal water intoxication because it has an antidiuretic effect. So we have to be careful with Pitocin. It is a dangerous medication. We're at greater risk for infection, chorioamnionitis, and then, C-section. So there are risks to induction. So our techniques, we can start with those cervical ripening methods. So there's lots of different medications that we can use, like prostaglandin based medications that help to promote that cervix to soften up, maybe open a little bit, maybe thin a little bit. And this can decrease our need for like lots and lots of Pitocin, or maybe Pitocin at all. Like some people just need cervical ripening, and that in itself will kick them into labor. So it just depends. I've had a few people that just had cervical ripening and then their body just kind of took over. Or we can use mechanical methods. So there are catheters with balloons on the end that we can insert into the cervix, and then we we fill those balloons with saline, and it puts pressure on the cervix and allows the cervix to open up and thin out that way. We can break mom's water, and sometimes that's all it takes to get her labor started. Or there's these things called laminaria. Laminaria are seaweed sticks. So we put seaweed sticks up into the cervix, and then we wet, so we get like a lap sponge that's wet. We put that up in there, and the seaweed soaks up that water, and then the diameter of the seaweed sticks gets larger and larger, and it helps to open that cervix up. And then we also have chemical agents. So these are things like Cytotec and Cervidil. So Cytotec comes in like pill form that you can place either rectally, vaginally, or you can take it orally. Cervidil is like a little mini tampon looking thing. It has a string on it. So you put the larger part up by the cervix, and there's like a little string that hangs out, so it can be removed at any time. Whereas Cytotec is a pill that dissolves. And then Pitocin or oxytocin. So that would be run through an IV. And it has to be given as a secondary infusion. And when we hook up our Pitocin to our main line, we run lactated ringers on all of our pregnant women. On her main line, we would hook her Pitocin up to the closest port to the IV site. That way, if we stop the Pitocin, then only a small amount of that leftover Pitocin in the tube would get into her vein, and not the entire tubing. So each little bit of Pitocin really makes a difference. So we don't want any extra in there if we're having issues or something. So always the closest port to the IV. And it's a high risk medication, so we put labels all over it. Usually we have another nurse check the dose. Like when you start Pitocin, you check it together to make sure everything is appropriate, you've got the appropriate order. And then we're obviously monitoring our uterine activity, fetal heart rate, and then we as nurses titrate that Pitocin based on our orders, and we need to know how to titrate it and respond to any kind of decels or changes in variability. So that's just something you learn with time as you become a labor nurse. Okay, so here's Cervidil. So like I said, it's like a mini tampon. Here's a catheter. This is called a Cook's catheter. So it has a balloon on each side. You blow those up with like 60 cc's, and it puts all this pressure on the cervix. And then this is what laminaria looks like. Usually you have several sticks of laminaria, not just one. And there's different sizes. There's like a small, medium, large laminaria. So you just fit as many as you can. We as nurses don't place laminaria or Cook's catheters. That's the provider will place these, but we do place Cervidil and Cytotec. There's also something called Prostin gel. It's like a gel-based prostaglandin that we can insert as well. Okay, operative vaginal birth. So this would be when we need to use a tool during the vaginal birth. So that could be forceps or a vacuum. Forceps aren't used quite as often anymore. We typically use vacuums now. If somebody's really good with forceps, they're great, but I feel like a lot of programs now, like when doctors are training, they don't even do forceps anymore, which is really crazy. So probably you're going to see mostly vacuum deliveries. We also can use these tools during a C-section because, believe it or not, babies can get stuck during a C-section as well. And so sometimes they have to place a vacuum or forceps to pull the baby out from the abdomen. So here's just an example of some different vacuums. They have different shapes to the end of the vacuum. So there's a bell or a mushroom, and then this is a little kiwi vacuum. There's a pump on the end that the provider will pump up once they have it placed, and it creates suction on the baby's head. And then when mom pushes, the provider will pull at the same time. So it just gives a little bit of assistance. These are great if mom has been pushing for several hours and she's already been laboring for 24 hours and she's just so exhausted and she just needs a little bit of help, a little boost. But oftentimes they will cut an episiotomy before this to create space, and they only are allowed to do so many pulls. We have to document when it's placed. If it does pop off, we have to count how many pop-offs there are. We have to count how many pulls there are. So there are a lot of different rules for that, and it just depends on the facility. So I won't give you any specifics, but here's forceps. There's different shapes and types of forceps. Depending on the position the baby's in, the provider will let you know which type of forceps to grab for them. And they place them beside the baby's head, and then same thing, mom pushes, and then the provider will pull. So both of these can have risks associated with them, obviously. So they can have risks of bruising, lacerations to the baby, abrasions, nerve injury, especially with those forceps. You can see this is right by the baby's head and face, so we can have facial nerve injury. Cephalohematoma, so remember that collection of blood on the skull underneath the bone. Hemorrhage, intracranial hemorrhage. And then mom can also have increased lacerations and hematoma. Okay, and then episiotomy. So this is an incision of the perineum just before birth. I know I mentioned that it's best to have one kind of off to the side, and that way if it does tear a little bit more, it's not tearing into the rectum. Indications for an episiotomy would be if we have a shoulder dystocia and we just need all the space that we can get, if they're going to do a forceps or vacuum assisted birth, or if baby's in that OP position. Sometimes we just need a little extra room in the perineum to get that head out. So there's that mediolateral appease. Okay, and then perineal care. After delivery, we have ice packs that we change periodically for the first 24, 48 hours. After 24 hours, they can also do like some heat packs or sitz baths are really nice. Sitz baths are just like warm water that you're kind of cleaning the area. It just can be really soothing. Daily wash with soap and water and then pat dry. Using a peri bottle or a squeeze bottle with warm water when they use the bathroom is super helpful. It helps because the urine can be, when they urinate and it touches the perineum, if they've had any kind of tear or sutures, it really, really burns. And just in general, it's just very uncomfortable. So having that warm water down there while they urinate kind of dilutes the urine, makes it more comfortable, and it also helps to keep things nice and clean. We always want to blot that area or dab that area. We don't want to wipe, and then always front to back. And then removing our pads front to back as well. We don't want to bring anything forward, and then keeping our pads clean and dry as much as possible, and then doing that RETA, that redness, edema, ecchymosis, drainage, and approximation. So making sure that that wound is not showing any signs of infection. Okay, and then a little bit about C-sections. So our C-section rate in the US does continue to increase, and we have kind of a high primary C-section rate. So like your very first delivery is a C-section. And then oftentimes people, once they've had a C-section, they will want another C-section, or certain providers will want another C-section. We'll talk a little bit about something called VBAC, which is a vaginal delivery after C-section. You have to qualify certain things to be a good candidate for that. So why is the C-section rate high? We have increased obesity in our country. We have increased induction rates, and we have older women who are getting pregnant, so delayed childbearing. So all of those things can just increase your risk of C-section. And then the preferred incision on the uterus for a C-section is a low transverse. So we'll look at some pictures here to show you what that is. So our skin incision doesn't matter as much as our uterine one does. So skin incision is what we see on the outside. So oftentimes it's going to be this low into like the pubic hair area almost. That's called a Pfannenstiel incision versus a vertical incision. So vertical incisions are quicker to perform and they can be extended, but they don't heal quite as well. And, you know, people, you can't hide them as well. So it's kind of an aesthetic thing as well. But if it's an emergency, like if we're running somebody back to the OR, we've got to get that baby out quickly. Oftentimes they will do a vertical incision just because you can very quickly get to the uterus and have great visualization. So that could be why you see some people with a vertical incision. Whereas a Pfannenstiel is more common for like your scheduled C-sections where you have, you've got time, you don't have all these risk factors. This was something that was on the schedule. It's not just like thrown together. So, and then our skin incisions, are these, so uterine incision. So this is showing you inside on the actual uterus. So this is the typical incision on the uterus, is a low transverse. So this is the best type of incision if you want to later maybe try a vaginal birth for a subsequent pregnancy. There's less blood loss with this type of incision, less likely that you're going to have adhesions. So it just depends. This is our normal incision that we would do for a scheduled C-section. Now, a low vertical, so up and down, is you cannot have a VBAC or a vaginal birth if you have any kind of vertical incision, especially this classical, which is up a little bit higher. So these ones would be of preterm babies. Sometimes they'll do a vertical incision, or emergency situations just so they can get to the baby as quick as possible, or depending on the placenta. Sometimes if the placenta, maybe the placenta is implanted here down low, then we would have to cut up high. So it just really depends on the entire scenario of that pregnancy, which incision that they make. But this is the most common, is the low transverse. Okay, so preoperative considerations. So we have scheduled C-section versus like our emergency or stat C-sections. We also have urgent C-sections, which usually have to go within 30 minutes versus a stat, which is like within minutes. So kind of standard pre-op procedures, we have to obtain consent. They're going to get an IV. They need to be NPO. We're going to shave the perineum, just like where the incision goes. They're going to have a Foley placed. They're going to talk with anesthesia. They're going to get an antibiotic. A lot of times we'll give them an antacid like Bicitra. So all of these things would be in a non-emergent situation. When you're in an emergency, a lot of those things you just kind of throw together. If they're not NPO, they're not NPO. We can't wait 8 hours. Sometimes we just get verbal consent, and then later we'll have them sign it. We just do what we can. Just depends on how much time you have. And then a significant other, father of the baby, or whoever that person brought with them, usually is allowed in the operating room as long as that person has spinal anesthesia or regional anesthesia and everybody is stable. So as long as mom and baby are stable, then they can hold the baby while mom is having everything sewn back up at the end of the procedure. There's a video if you guys want to watch a C-section. I can't remember if this is a cartoon or like a real C-section, but you guys are welcome to watch that. And then our recovery care is basically the same. So those first couple of hours, you are staying with the labor and delivery nurse. And so in this particular scenario with a C-section, we're going to be in the PACU area, the post-operative area. We're going to do our normal postpartum assessment. So every 15 minutes, doing those vital signs, checking her fundus, checking her bleeding or her lochia, getting her set with, maybe ice chips, crackers, getting her cleaned up. All of that's the same. Now, if she had a C-section, she's also going to be on cardiac monitoring back in the PACU, and we're also going to be monitoring her abdomen. So she'll have a big dressing and ABD on. We want to make sure that we don't see any blood or drainage on that. We're going to manage her pain. We're going to assess her Foley, because that Foley remains in for a little while. And then just kind of following our, orders from anesthesia. So a lot of times they just have like a protocol for pain management that we follow. Okay, so a VBAC, or a vaginal birth after cesarean, you may also hear TOLAC, which is a trial of labor after a cesarean. So a lot of people will say they have a TOLACer. So this person has only had a C-section and now she's trying for a labor. And then once she actually has a successful vaginal delivery, then she becomes a VBAC. That makes sense, because this is a trial of labor versus a VBAC that actually happened. So I don't know. I feel people interchange those back and forth. But so some people they really, after a C-section, they really want to experience a vaginal birth. And some people the risks of it. So there are more risks to having a surgery than a vaginal birth for some women. So It just depends. Some people just want that experience if they are a good candidate for it. It used to be that once you've had a C-section, you always have to have C-sections, but that's really not the standard anymore. The biggest risk is going to be uterine rupture, where the uterus actually opens up from that previous incision. So any pregnancy is at risk for uterine rupture. It is very rare, but especially if they've had surgery on the uterus, obviously that risk is going to go up. So when we are talking with our patients about a VBAC, they do have to be consented on those risks and the benefits, and so that they know that that is an option or something that could happen during that labor process. So our contraindications, people that are not a candidate for a TOLAC VBAC, would be somebody who's had a previous uterine rupture or uterine surgery. So uterine surgery would be like, I'm not including a C-section when I say that. If they had fibroids and they had what's called a myomectomy, where they had those fibroids surgically removed, that is a contraindication. Or maybe they have some type of uterine anomaly, like they have uterine didelphys, where they have 2 whole uteruses or something like that. Some type of congenital malformation, they would be contraindicated for a VBAC. If they had a classical uterine incision, so that up and down vertical, or sometimes people have a T incision, so they have both a horizontal and a vertical, which can happen if they're having trouble getting baby out, they have to T the uterus. So then you have these 2 huge incisions. You're really, really at risk for the uterus to open up. If they have a placenta previa or any other kind of medical reason where they can't have a vaginal delivery, then we're obviously not going to have a VBAC. If they've had a lot of C-sections. So this depends on the provider. Some places, if you've had 1 C-section, you can have a VBAC, but if you've had 2, you cannot. Other providers are okay if you've had 2, other are okay if you've had 3. So it depends on where you're getting your care. The most I've ever seen is 2. If somebody's had 2 C-sections, where I worked, they could try a VBAC, but if they had 3 C-sections, they could not try a VBAC. So that's just my experience. Also depends on what was the reason that they had their C-section. Was it because that baby was breech and this current baby is head down? Well, then that's a totally different scenario. Was it because they had a 10-pound baby and now they're set to have another 10-pound baby? They're probably not going to be successful again because it's a big baby again. Also, if they do not go into labor on their own and we need to induce their labor, a lot of providers will not let them VBAC if we need to give them something to get them into labor, because that's another risk already for uterine rupture, is to give Pitocin. So we don't want to do that. And then it depends on staffing, facility, and provider. So VBACs, to have a VBAC patient in your facility, you have to meet certain criteria. You have to have an OB provider in-house. You have to have an anesthesia provider in-house, and that patient has to be one-on-one with a nurse. You have to have a NICU. You have to have all these things in place. So if your facility does not have those things, then that person cannot VBAC at that facility. So those are all things that you would know ahead of time. Okay, so what are our nursing considerations? We are going to observe the fetal response. So during labor, we are watching very closely. This person's going to be on continuous monitoring. We are watching closely for any bradycardia, tachycardia, and late decelerations, just like we would with any other patient, but we're going to be hyper vigilant. And then we're watching mom, her contractions. If we notice that she's having tachysystole, which is where you have that hyper stimulation of the uterus. So if you have greater than 5 contractions in 10 minutes, we need to slow those contractions down because we need to make sure that we are not overloading this uterus that's already at higher risk for rupture. And then if mom starts reporting pain at the prior incision site, we need to report that immediately to the provider. I had a patient who had a uterine rupture, and that was the only thing. All of a sudden, she was having a burning sensation at her previous incision site. And by the time we got her back to the OR, her uterus had opened up. Timing was great, though. She did great, baby did great, but we really have to take that very seriously. So a uterine rupture is another OB emergency. This is where the uterus opens up. It completely just opens up, bleeding everywhere. Baby is now in the abdomen. How this presents is abdominal pain. Your abdomen is very tender, very rigid if it's full of blood. It can lead to chest pain or referred like shoulder pain. Shock. We can have, of course, abnormal fetal heart rate patterns, so either bradycardia or like lates right before this happens, or absent fetal heart sounds if baby is in the abdomen now, or no longer getting oxygen from the placenta. You can have your contractions that are going and then all of a sudden they're gone because the uterus is no longer contracting because the uterus is no longer together. And then if you're putting your hands on the abdomen, you can palpate the fetus outside of the uterus. So this would be, this has already happened, and that's pretty rare. So this is kind of what I'm describing here, is the uterus opens up and now the baby is coming out of the uterus within the abdomen. Your fetal heart rate you see here, this is showing some variables. And then we have bradycardia, and then we just have sustained bradycardia here, and our contractions stopped. So this is what it actually looks like on a real uterus. And then this is what's called a window, a uterine window. So this is the uterus. Here's your sac that the baby is in, and there's just a thin membrane. So this is still the uterus here, and there's a thin membrane, but you can see inside the uterus. That's why it's called a window. So this uterus is very, very close to rupturing. So this is what would happen right before this. Okay, so then uterine inversion. So this occurs when the uterus completely or partly turns inside out. So when we talked about like doing our fundal massages postpartum, we talked about needing to put that second hand down by the pubic bone because it helps to keep the uterus in place while you're massaging the fundus. What can happen is if you just massage the fundus, it can actually turn inside out on itself and come out the vagina, and then it's not able to contract down because it's inside out, and so then we're just bleeding and bleeding and bleeding, and that can lead to shock and death. This can also happen excuse me, I'm sorry, this typically happens the third stage of labor. So the placenta has come out and then this can happen. It is very uncommon. I've seen a prolapse, but I haven't seen like an inversion before. So it is pretty rare. Obviously, it can cause mass amounts of blood loss, and if we're not able to get it back in and contracted down, it can lead to death. So our treatment is to manually reinsert, your provider, not you as the nurse, to reinsert, and then maybe a hysterectomy if we can't get control of that bleeding. So here's kind of what a manual insertion looks like, pretty barbaric, but so the uterus was previously up here, it has turned inside out and come out. The provider takes their hand and puts everything back inside, and then we're going to need hemorrhage medications and as much as we can to get that uterus to contract back down to stop that bleeding. All right, another OB emergency is an amniotic fluid embolism, or AFE. This is also very rare, but I actually just recently heard about one of these like in the news. But it occurs when, from what we know, we don't know a whole lot about this, but when amniotic fluid or some type of fetal material gets into the maternal bloodstream somehow, and then mom has kind of like an allergic reaction to this foreign invader, basically. This happens very, very suddenly. She will be fine, and then typically the patient will report maybe like a sense that something's not right, or I feel like something bad is going to happen, that impending doom, and then all of a sudden she is in respiratory distress and coding. So symptoms: acute respiratory distress, cyanosis, hypotension, sudden cardiorespiratory arrest, and this needs to be identified immediately. Compressions need to start immediately, and then a lot of times these women cannot be saved. This is a really, really scary thing. I have never had this happen to me, but I have had this happen on my unit where the mom did pass away. We don't have any therapy or medications. All we have are advanced cardiac life support. So all we can do is recognize this, start CPR, and call for help immediately. Oh, I guess that's all I have on amniotic fluid. Okay. Trauma. So trauma can mean a lot of different things, but motor vehicle accidents, assaults, suicide, a big fall if mom falls and hits her belly. And then we talked about how that can cause the placenta to separate from the uterus. So we can have that placental abruption leading to hemorrhage, injury to the baby. We're going to treat trauma similar to a non-pregnant patient. So we have to stabilize that mom and then try to work with everything else. So it just depends on what the trauma is. So I had mentioned like cardio or a motor vehicle accident, like broken bones, like they're going to be in the emergency room. We're going to try to stabilize them. Simultaneously, a labor nurse will come down and monitor the baby. Occasionally they will have to do like a crash C-section in the ER. So just like at the bedside in the trauma room, sometimes they will deliver a baby. So it usually does not end well when that happens, and then, okay, so I had mentioned we would do a little bit about perinatal loss. I think I only have just one slide on perinatal loss, but so this encompasses miscarriage, stillbirth, and neonatal death. So depending on kind of where you're working, if you're working on labor and delivery or the NICU, or you're working at a clinic, you can experience any of those losses. Treatment, so once it is identified that we've had a loss of this baby, we try to induce labor as soon as possible because now mom is at risk for infection and kind of other things that the body does when we have a loss of a baby. Sometimes people will opt to do a C-section, but we try to encourage a vaginal delivery when we can, just because the risks to mom are lower than a major abdominal surgery. Our nursing care, it's going to be similar as far as like how often we're doing vital signs and the medications that we're using. We're not monitoring a baby, so that part is different, but way more emotional care, and we do a lot more with like when baby is born. I talked about like things that we do. We do a lot of mementos, so like hand and footprints. We dress babies, we bathe them, we take pictures. Like I thought this was such a beautiful picture. And then, the parents can decline any of this, or we can do all of it and then they can come get it later, or we can give it to somebody else if they don't want to see any of it. If they don't want to hold the baby, that's okay. There is this thing here. This is a cuddle cot. So it's a little pad that goes in the bassinet. It's a cooling pad, and you can set the baby on there to keep their body cold, and it helps to preserve them longer so the family can spend more time with the baby. I've had babies that were born alive, but were too small to be able to resuscitate and to intubate. And the parents didn't want to see the baby. And so we would take the baby, and where I worked, we had a special room that we would go to. And I've held the babies while they passed away. So they weren't alone. And so that's part of what we do as nurses. So it's a really tricky thing to navigate, and everyone responds, like your patient really responds very differently. Some patients, of course, are completely devastated and really are just having trouble even grasping what is happening. And then other patients really are, I want to say fine. They're not fine, but present as fine. They can have conversations, they can respond well. Other people are just numb and they really are not responding to anything at all. So you just really never know. We're all different. And even as nurses, we don't know how we're going to respond in this situation, but, and then I had mentioned earlier, if the delivery is after, or the gestational age is after 20 weeks, we would do a birth certificate and a death certificate. So there's a lot of documentation that we do. We also will contact pastoral services if that's something that the patient wants, and they can have somebody come and bless the baby. We help them navigate with a funeral home if they do want a funeral. We figure out if they want the baby any kind of like autopsy, things like that. So a lot of different documentation and education that we give from that standpoint. Okay, whew, we did it.